check 1, 2. Okay. Good morning, and thank you and welcome. Whether you're here in person or looking online, we'd like to welcome you to our GP study morning for orthopaedic and spinal services. My name's Chris Carr, and I'm the Orthopaedic and Spinal Operations Manager at Blackrock Clinic. We are currently in the midst of doing a review of our orthopaedic and spinal services, so we're most interested in getting any feedback that you might have regarding our service. We'll be here all morning and love to take any questions that you might have, or at a later date we'll be reaching out to you via survey. So if there's anything that you think we could do to improve the service, then please let us know. What we're doing this morning is, the format is, we'll be doing a half an hour presentation followed by discussion and questions from our panel. If you have any questions, please wait until you've got the microphone, because we've got a big online audience that will be looking on this morning and they won't be able to hear otherwise. If you're looking online, then please send through your questions via email to events@blackrock-clinic.com. We've got a great lineup this morning. And first up, we have Mr. Diarmaid Maloney. He's a consultant orthopaedic surgeon. His practice is focused predominantly on shoulder and elbow surgery, including both traumatic and degenerative conditions. He's a founding member of the Irish Shoulder and Orthopaedic Society, and we're delighted to have him here this morning. He works out of Blackrock Clinic and Talbot Hospital. So over to you, Mr. Maloney.
So good morning, everybody. So what I've been asked to talk today about is shoulder conditions, and that forms the predominant part of my practice. It's needless to say, it's a very common problem. I suppose if you look at across GP practices, I think most people would say a lot of MSK stuff comes in the door, about 30% of a lot of practices, so I'm told. And from studies overseas, we know that of that group, 30% will relate to the shoulder, so it's a common problem. Not everybody needs a shoulder surgeon, but I suppose having a background knowledge about what's going on with a lot of these patients is important. So one of the issues we have in shoulder surgery is the evolution of technology around what we do, and that relates to predominantly to arthroscopic surgery, but also to the evolution of MRI and the ease of access of MRI as well, but also patient demand. And so this picture that we see here of the octogenarian skydiving is actually not that uncommon, and I have a patient of my own who also has been a skydiver, and she's 78. So it does happen, right? So these people are definitely much more active into their 70s and 80s than they used to be, and therefore their demands around what their shoulders can do definitely has increased. From the point of view of diagnoses around the shoulder, every time I go to a shoulder meeting, there's some new acronym that's been thrown out there based on some MRI finding or arthroscopic finding that has been developed by or identified by somebody, and I kid you not, every time I go to a meeting there's something new. And so it's important to remember that not all of these problems relate to something that specifically needs to be fixed or needs a surgical solution to it. They're often just a diagnostic finding or often an incidental finding on imaging or on arthroscopy. I suppose the evolution of arthroscopic techniques has definitely improved matters around the shoulder. It's much more atraumatic to treat somebody arthroscopically, but there's still a place for open surgery, and a lot of the time where you have triumph of techniques over a reason, arthroscopic techniques can often be a little bit too complicated and too time consuming, and open surgery is often just as useful. And indeed there's plenty of procedures that are better done open versus arthroscopic based on what's out there. So not to throw the baby out with the bathwater, but there definitely is an improvement in both diagnosis and in treatment of many conditions because of the evolution of arthroscopy. The other thing I wanted to mention today is the evolution of arthroplasty around shoulders, around shoulder conditions. And I guess when I came back from fellowship, first of all, I went to visit a buddy of mine, a GP who works in the Midlands, and who was shocked to hear that shoulder arthroplasty even existed. That, you know, my God, you guys do shoulder replacements. I never even heard of it. And it is true that shoulder replacement surgery is much less frequent than knee or hip surgery, typically to the tune versus hip surgery hip replacement in the US anyway. For every 5 hips done, there's only 1 shoulder done, and I would consider that to be even a high number, to be honest. So, but they are out there, and I'll touch on those later on as to what the indications and the types are. But in broad terms, the conditions that affect the shoulder haven't changed. I mean, patients really haven't changed apart from the increase in demand, as I say. And so the biggest problems we have are instability, arthritis, and rotator cuff problems, and they're the major ones. But it's important to remember, so they're the major ones that require a surgeon to look at them. But it's important to remember that there's plenty of stuff that radiologically is absolutely normal, as in this X-ray here is a perfectly normal AP of the shoulder. But this patient may have capsulitis or a tendinopathy or an impingement or a bursitis or maybe pain related to the AC joint or biceps irritation, all of which really are clinical diagnoses. And so all these conditions that are identified on MRI, or all the findings that are identified on MRI, the MRI is really just an adjunct to the clinical exam, and it's important that the patient understands that as well, because frequently they'll come in with an MRI that says you've got a rotator cuff tear, and they're convinced that the shoulder pain is related to that, but in fact the problem may be the AC joint or their biceps or something else. So I find most of the time in meetings like this that most people want to talk about the rotator cuff. That's the biggest grey area. In fairness, most of the time somebody who's got bad arthritis and serious pain related to it, or somebody who's got a lot of instability, I suppose the treatment algorithm is a little bit easier to establish. But in rotator cuff disease, there's a lot of grey. And that's why most of the time in these meetings people want to talk about that. Now, this isn't necessarily a didactic morning, so if you feel that you want to ask any questions about other things, that's absolutely fine. But I'll talk about the cuff at the beginning, and a little bit about arthroplasty, and a little bit about instability, capsulitis, and impingement, and we can digress from there. So basically, in the rotator cuff, there are 4 tendons. Moving from the back through to the front, the teres minor, infraspinatus predominantly are external rotators. The supraspinatus is predominantly an initiator of abduction, and subscapularis is an internal rotator. So when you're examining the patient, and again we'll go through exam techniques later, it's important to look for wasting in these muscle groups. You want to determine whether or not patients have pain on each of these movements, and particularly and resistance to those movements, to see which part of the rotator cuff is involved. Important also to ask the patient, what are their symptoms effectively? Is this a functional problem? Is it a pain problem? Are they stiff? Are they weak? Are they painful? And how long has it been going on? A lot of the time you can have asymptomatic rotator cuff tears, however, and in fact there's a lot of literature out there to show that over the age of 50, effectively 50% of the population have asymptomatic MRI-proven rotator cuff disease. Okay, so just having a tear on an MRI scan doesn't necessarily make you abnormal. All right, it pretty much makes you, for half the population, normal. It's only when the tears become symptomatic, or they start to expand, or the patient has an injury on top of a pre-existing tear, which worsens the situation, that they may end up requiring something for it. So the rotator cuff, in terms of its function, obviously they are muscles, so they are motors. They are involved in human rotation and movement, but they also provide stability during elevation. And effectively, the shoulder joint is a very complex joint. To reach up here, it takes 31 different muscles to fire in the correct sequence. And as a result, you need a stable fulcrum at the base of that. And what that is provided by is the function of the rotator cuff. So it keeps the ball in the socket while it's elevated over the patient's head. There's also a very complex relationship between the intrinsic muscles inside the shoulder, effectively the rotator cuff, the capsulo-ligamentous structures in the shoulder, and the external muscles, lat dorsi, pectoralis major, all the bigger muscles on the outside. They're all intimately linked, and the interaction between those is very, very complicated. But effectively, what you need is a stable fulcrum for the arm to move, and that's what the rotator cuff provides. So I guess if we're going to talk about pathology around the rotator cuff, we have to answer a few questions. So the first is, what happens if the rotator cuff tears or fails? What's the natural history of that? So is it actually important to do anything with them? Will they just be fine if we do nothing? And if we are going to repair them, how do we decide when to repair them, and what happens thereafter? So how does the patient rehab? How does this tendon tear then heal? And what can we expect at the end? And I suppose rotator cuff registries, just like there are registries in other parts of orthopedic surgery, there are also registries in rotator cuff disease. And so we know downstream how these patients are going to do and what we can tell them when we meet them in the clinic in advance of considering surgery. So when the rotator cuff fails, when there's a tear in the cuff, the load that the tendon would have carried is transferred to the tendons either side of it. It is a cuff, so that you have a gradual progression of transfer of load, and that means that the remaining rotator cuff then has to take up the tension for that. And that's the reason why over time, about 50% of tears will extend in size. But because the tendon also takes up the slack, you can have small tears in the middle, or even medium tears in the middle of the rotator cuff, typically in the supraspinatus, where the patient's function is absolutely unimpeded because the other muscles make up for the loss of muscle that's there. There is a progressive ischemia, so that when a tendon tears, these fibers either side of it are more prone to disease because they have less blood supply. because the gap is created and articular fluid gets into the gap, these tendons will not heal without being surgically treated. But that, again, not to say that every tendon needs to have an operation, but just to understand that the tendon will not heal. It's a question of, does the tendon remain symptomatic because of inflammatory conditions or persistent weakness, or can it get better through rehabilitation in general? Okay, and that's one of the reasons why when people ask me, oh, should I not be injecting patients who have symptomatic rotator cuff disease? The answer is effectively, it's not going to make a difference to whether or not the tendon heals, because the tendon will not heal whether or not you inject them. So the injection is there to provide an anti-inflammatory effect. So it is perfectly reasonable to inject somebody who has an MRI-proven small rotator cuff tear. The only caveat to that is that if the patient has severe dysfunction in their arm where they can't move it and you're considering something surgical, if you do the injection, you can't operate for 3 months because it increases the rate of infection. So that's the only caveat to that. The other thing that happens with tendons is, just like any part of the body, if it's not being used, it degenerates. And typically in rotator cuff disease, what happens is the muscles turn to fat, and it's very hard to retrieve that. So if you do get a big tear where somebody has a lot of dysfunction, those tendons will turn to fat, and retrieving that is quite difficult. So this is just a sample of what the MRI findings can be like. So I'm just going to use the pointer for this. Hopefully you can see that. So this is a rotator cuff tear here. This is looking at the shoulder front on. So that's the humeral head. This is the glenoid. This is the supraspinatus tendon, which ordinarily, that's the tip of it there, should be way over here on the rotator cuff footprint. So this is a supraspinatus tear, but you can have isolated tears in any of the muscles. So looking at the shoulder from the top down, this here is the humeral head, this is the glenoid again looking from above, and this is the subscapularis muscle here where the arrow is. So that's a subscapularis tear. And likewise, you can have the same in the infraspinatus here. So again, looking at the shoulder from the top down, in this case, the subscap is intact, and this is the infraspinatus tear at the back. So each of these muscles can be torn in isolation or indeed in combination. And the outcome then clinically or in terms of dysfunction is related to which muscle is involved. So why would we at all repair cuffs? We know that 50% of asymptomatic tears will eventually become symptomatic. We know that nearly half will increase in size over time, and that where you have big tears, there is a direct relationship between the onset of arthrosis and a pre-existing rotator cuff disease. And that's one of the things I'll talk about when we're talking about arthroplasty, because there's two distinct entities in terms of arthritis, degenerative arthritis that you would be familiar with in the hip and the knee, and arthritis around the shoulder are a little bit different, because mechanical arthritis called rotator cuff arthropathy, which exists because of poor mechanical environment inside the shoulder, is probably more common in terms of generating degenerative disease than primary OA is. Okay. We also know that fatty degeneration and atrophy, which, as I've mentioned, happens when the tendon is not being loaded, does affect function, and that it progresses pretty rapidly. But we also know that cuff repair has a lasting improvement on pain and function. And so we know that these surgeries do actually work and the patients are happy. The difficulty is that it takes them a long time to get there. And so it's important that the patient understands that when they go down the route of surgery for a rotator cuff problem, they're going to be going through rehab for several months afterwards. And what I usually tell my patients is, you're not going to like me very much at 3 months because you're still going to be stiff and sore and a little bit unhappy with your progress, but hopefully between 6 and 12 months you'll be happy. And that's the reality, and the patient needs to understand that. Okay, it's not like, where you can get up and walk on your hip replacement the next day, or get up and walk on your knee replacement the next day. It doesn't happen like that, and the reason for that is you've got to wait for the tendon to heal, because the process around tendon healing takes altogether about 15 weeks. Because if you go in to a rotator cuff, having done a rotator cuff repair in it at 8 weeks, and look at it, macroscopically it looks to be healed and it looks great, but that's all scar tissue and doesn't have any tensile strength. So in order for the tendon to recover properly, you have to wait for these little fibers called Sharpie's fibers to bed into the bone. They don't even appear microscopically until week 12, and they're not mature until week 15 in terms of being able to tolerate load. And so at the beginning, with your rehab, you're trying to keep the shoulder mobile so it doesn't get capsulitic and stiff, but you don't want to challenge the tendon. You can only really challenge the tendon after week 6 to 12. So it's important that the patient understands all of that. And so the discussion pre-operatively with these patients is really, really important. So we know from the cuff registry in New Zealand that the patients will be much better at 6 months than it is today, but they can continue to make improvements up to 2 years post-operatively. And so I always tell them, don't give up, keep trying, keep trying, keep trying. And so one of the single biggest problems they often have is their cuff feels nice and strong at 6 months, but they're still stiff, and that's because they still have some residual capsulitis. And so at that point, then moving on to passive stretching techniques, and that can often generate yet more range of motion, yet more function for them. And every 5 degrees in elevation will make a huge difference to their function overall. Every 5 degrees in external rotation will make a huge difference to their function overall. So, but as I mentioned, not every cuff needs to be fixed because there's a lot of rotator cuff disease out there, and most of it is asymptomatic, okay? And the key thing is when you're examining your patient, is the rotator cuff the source of the problem? So test the cuff, see is that what generates the pain, or simply ask them, is your problem a lack of range? If it's a lack of range, then you check it out, you examine them and see is the lack of range because of stiffness or is it because they don't have the motor? And that's effectively what it boils down to. When you talk to these patients, you need to ask them, have they had any trauma? Is pain a problem or is it just weakness? If they have pain, where is the pain? Because obviously if somebody has pain down around their elbow, it's unlikely to be coming from the shoulder, but they can have pain that radiates all the way down to the elbow. It may well become from the shoulder. Typically people with rotator cuff disease will not feel it in here, in the glenohumeral joint. They usually feel it over the deltoid. That's usually where they feel it. Are there any associated mechanical symptoms? Because they may have done something to their labrum or to their biceps at the same time. There may be clicking or popping going on in the joint. But beware of periscapular dyskinesia. So that's a fancy term for basically saying that their shoulder blade's not working properly. If somebody gets a painful shoulder, they will hitch it up like this, and the movements that they have in their shoulder blade afterwards are not normal. And as a result, they can often get clicking and popping around the shoulder blade, which is not really because of pathology inside the glenohumeral joint. Weakness and stiffness, obviously problems around rotator cuff disease. So effectively, if you're trying to evaluate these patients, I think I like this slide because it just kind of distills down what you're looking for. So if somebody has good range and good motor, but they've got pain, that means they probably at most have a small cuff. So if they can elevate, they feel strong, but they're just a bit sore when you're testing it, it may be small. If they have a good motor but bad range, but that means that their motors are functioning well, they're not particularly sore, and I'll show you some techniques for examining that later. But they've got bad range, then it's more likely to be something that's stiffening the joint, so something like capsulitis, where if they're very, very sore, particularly at end of range, or arthritis if they have through range pain with some crepitus, then that might be the reason for that. If they have good range but a bad motor, so if their mobility passively in the shoulder is good, so they're not that, you can move the arm for them, it doesn't feel too bad, but they can't elevate their arm themselves, that's a big red flag, definitely somebody that needs to be sent for an MRI scan because they may well have a massive rotator cuff tear. And if they've got both bad range and bad motors, the imaging will tell you what's going on there. So again, imaging required in that instance. And one of the catch terms we have for patients who have in the red box here, the good range but the bad motor, is pseudoparalysis. So it's the patient that comes into you. They said they were starting their lawn, this time of year, perfect time for it, they were starting their lawnmower, they felt something pop in their shoulder 6 weeks ago, and their shoulder was painful, they didn't think much of it, but now they still can't move their arm and they're starting to get worried. That's a red flag. It's like, okay, I need to go and get this patient some imaging fairly soon and get a surgical opinion. The patient will come in and they'll say, oh yeah, I can move my arm all right, like that. Okay, so, but they can't actually in a controlled fashion lift the arm up in the air. What they're doing is they're developing tricks to overcome the loss of their rotator cuff, and that's called pseudoparalysis. So again, just like in instability, there are lots of different acronyms, and we've looked at that slide already, but the same is true for, shall we say, surgically irrelevant, but nonetheless relevant to the patient from the point of view of their pain findings on MRI. So tendinopathy, calcific tendinopathy, bursitis, partial thickness tears, intersubstance tears, pasta lesions like this where you have a tear on the inner side of the rotator cuff, intersubstance tearing where it's in the middle of the rotator cuff but on the inner side and the outer side it's intact, or reverse pasta lesions where the tear is on the bursal side, are all relatively common findings on MRI. But in the end, the treatment plan for all of those is conservative management, injections, physiotherapy, try and mobilize these patients. Hopefully they'll get away without surgery, and I would say the number of people that come to surgery for conditions like this is probably in the order of 5 in 100 at the very most, okay? So most of these will do fine with injections and physiotherapy. The ones to watch out for, I think, is where you have medium, large and massive tears, where the tendon is retracted, where there is superior migration of the humeral head, so that will be seen in MRI and could be commented on the reports that are coming back to your practice. Rotator cuff arthropathy is a kind of a progression after the superior migration part, and that means they already have established arthritis related to the rotator cuff failure, and then pseudoparalysis. So pseudoparalysis is more of a clinical term, but the odd time you'll see that that the radiologist might say examine for pseudoparalysis, and again I've just demonstrated what that looks like. So fatty degeneration is what this is here. Hopefully you can. That's it there. So basically that is where the muscle belly degenerates or gets smaller, and you see the lighter colored material on the outside there is fat. It's just like the fat in the subcutaneous fat here on the MRI. So you see this is muscle and this is all fat here, right? By comparison to the bigger muscle on the outside here. All right, so that's what happens. The muscles eventually become degenerate. Superior migration, it's this one here, so that you can see that the glenohumeral joint itself isn't aligned properly. The humeral head has risen up and sits underneath the acromion, so that's what they represent, and they represent big rotator cuff disease. The configuration of the tear matters as well because it'll affect how the patient functions, but in addition, it means that some people can compensate for even medium-sized tears with the muscles either side, and that's because of the fact that these muscles on either side, the subscapularis and infraspinatus in particular, can often compensate for large supraspinatus tears, and that's the reason for that, is that effectively they set up a force couple. So I won't go into that in too much detail, but effectively what it does is it maintains the compression of the glenohumeral joint, it maintains the stable fulcrum so the patient can still mobilize their arm. So there are lots of controversies in the surgical world about rotator cuff disease. Should we be doing these open or arthroscopic or mini open? Should you be doing single versus double row? What configuration of anchors to do? Should you be doing other surgeries in combination with this? Should you be doing biceps tenotomies, tenodesis? All of these questions really are, really fine print, I would say. Not a whole lot of it really has been properly and effectively investigated, but it is something that's constantly discussed in the surgical world. But in the end of the day, what you're trying to establish for this patient is to retrieve their function for them by repairing the cuff, so as to provide that stable fulcrum I mentioned. So the timing of these problems, of treatment for these problems, so most people can have a trial of active conservative management. So patients who have acute and chronic symptoms with small tears on imaging, they have well compensated cuff function, so they can elevate their arm quite easily, and the pain has been there for less than 3 months. It's reasonable to inject that patient to try and deal with the inflammatory components of their problem, and then rehab the patient afterwards. Okay, and the rehab, and Darren will go through that shortly with you during the panel discussion, but effectively what you want to do here is create a stable base with good scapular control, and then rehab the remaining muscles in the rotator cuff, and hopefully they'll get away with it. For people who have a previously asymptomatic shoulder with a distinct index injury, who are pseudoparalytic, so just like I said, they come in, they cannot elevate their arm in a controlled fashion like this, or who have large full thickness tears on imaging, they tend to do better if they're operated on earlier. Okay, so again, the magic number here is the number 3. Effectively, if the scan shows that the tear is less than 3 centimeters in size, they are likely to do okay with conservative means. If it's more than 3 centimeters in size, then moving to surgery earlier is a better idea. So effectively, several studies will show that the outcome in small tears is not really related to timing, but if they are going to do better, they will do better in less than 3 months. So by that I mean somebody attends your clinic at point 0 with shoulder pain related to a rotator cuff tear. You do an injection for them, you send them for physiotherapy, they do okay for 6 weeks, they're improving all the time, they come back for a second injection at 6 weeks and go for more physiotherapy, and they're still improving at 3 months. You put those in the potentially successful box, and they can keep going with physiotherapy up until a year. But what we know is that if at a year they're still not happy with their outcome, they're unlikely to be happy with their outcome in the longer term. Okay, but if they're improving in the first 6 months, they are likely to do fine. If they're not improving with conservative measures in the first 3 months, we know that in the longer term they are unlikely to do well. Right, so again, just like I said about the size of the tear, the magic number for duration of treatment conservatively is also 3, so 3 months. So if they're doing well by active conservative management, that doesn't mean that they just go home and do nothing. It means they get a rehab program, and they have to do the homework, do the exercises, and you do an injection to facilitate that. So the injection is there to give them the opportunity to do the rehab, take away the inflammatory pain. If, however, the patient is not doing well with conservative measures, they have symptoms for more than a year, if their symptoms are deteriorating, or they have persistent disability in the arm, then they might well be a surgical candidate. So that's the difference with those. There's been, I suppose, to try and distill all the information that's out there, as you might imagine, for a topic as grey as rotator cuff disease, there's been lots of stuff. So meta-analyses have been done, and the American Academy has come up with its appropriate use criteria. And I guess effectively it's pretty intuitive. The bottom line is if somebody is improving with conservative measures, it's reasonable to continue with those. If somebody is not improving with conservative measures, then you should be thinking about something surgical. And for arthroplasty, I suppose that's a topic of major debate, is what to do with massive tears and pseudoparalysis that are not retrievable, where the tear is not retrievable. So that's where that last line comes in there, and I'll talk about that in a second. One of the things to watch out for with rotator cuff disease post-injury is obviously capsulitis, because you can have lots of people that come in with severe pain in their shoulder. They may have nasty changes in their MRI scan, but actually the problem relates to capsulitis, and in particular operating on somebody who has capsulitis or frozen shoulder too early in the post-injury phase can often lead to a very, very stormy post-operative course. So they get really, really painful. They get very, very inflamed. Now, sometimes you just have to, because the tear is so big that you know it's going to retract further if you don't move on it. But in general, it's a good idea to try and avoid operating on somebody with capsulitis. The other thing to watch out for is the patient who's over the age of 40 who attends with a primary dislocation. So they've dislocated their shoulder for the first time, they've gone to the A&E department, the A&E have done a post-reduction film which says your shoulder is back in joint, off which you know to physiotherapy, but they're not making progress with physio. So somebody over the age of 40 who dislocates the shoulder for the first time, it is unlikely that they'll have persistent instability down the track, and again we'll talk about that shortly, but what you do need to rule out is a rotator cuff tear. And even in the painful shoulder, it is possible to identify rotator cuff tears early on, and again we'll go through that in the exam section during the discussion. So for massive irreparable tears, you might have heard that sometimes rotator cuff tears are just too big, all right, and it is impossible to retrieve it. And effectively, the decision making about what to do for these patients depends on the patient demand, and also the findings both radiologically and also at arthroscopy, because it is again, when you go to shoulder meetings, there is always a different idea or a different strategy for dealing with these problems, and that's because by and large we know when you have lots of strategies for dealing with something, it's because none of them work particularly well, right? So the bottom line is that for massive rotator cuff disease with irretrievable cuff, particularly in the young person, it's a very, very, very difficult problem, and most of the techniques we're using for dealing with these are effectively salvage, all right? So what happens if the rotator cuff isn't treated at all? Somebody has a massive rotator cuff tear. Well, this is what happens. You get this progression here, as I said, this mechanical type of arthritis called rotator cuff arthropathy. And so eventually over time, the humeral head migrates more and more proximally. They get more and more degeneration in the shoulder. They start to get more and more painful, even for simple tasks. And eventually the humeral head starts to collapse like this. And that's effectively what rotator cuff arthropathy is, okay? And the solution for that these days is a reverse shoulder replacement, and that has revolutionized the treatment for these people. And again, I'll go through reverse shoulder replacement shortly. So in summary, for the rotator cuff, the evidence does support cuff repair. Patients do get a long-lasting outcome, and it's important to remember that the diagnosis, radiology is very, very helpful, but it's very important that you examine the patient thoroughly so as to know, is this finding on the MRI scan relevant to the patient's clinical picture? Non-operative management is certainly reasonable, small and medial tears. The timing is dependent on size, function and acuity, and in patients who have acute dysfunction, it's important to refer them early because they may require surgical intervention early if they have a massive tear. So, and then suitability for repair in massive tears depends on the amount of tendon retraction, whether or not there's a lot of fatty degeneration, and whether or not there's already pre-existing arthritis in the joint. So I'm going to talk briefly now about instability, because that's probably the second biggest tranche of, shall we say, surgical shoulder problems. In the past, we used to have this a thought process that basically you could fit people into two boxes. One was the sort of the multi-directional instability patient that had laxity, and the other was the traumatic patient. But actually what we're understanding now is there's a lot more to most patients, that each one of them will have one of three polar types. And so when a patient attends your clinic with shoulder instability, they will have a degree of muscle patterning. So because their shoulder is unstable, their muscles are firing abnormally to try and keep them located. They will also have a degree of laxity, and even the 25-year-old rugby player who has recurrent instability will have a degree of that, because their joint will have been injured so many times that the ligaments have healed in an elongated or lax fashion. And then the straightforward traumatic labral tears that you probably may have heard of. So everybody fits somewhere in this triangle here, which is known as the Stanmore triangle. As I mentioned earlier on, instability in general is a problem relating to younger patients. Where the patient is over 40 years of age, the most common cause of recurrent instability is not really related to capsulo-ligamentous failure, it's actually the cuff. So again, as we mentioned, keep an eye out for big cuff tears in patients who are currently unstable over the age of 40. So just thought I'd mention a couple of little cases, so just to put you in the picture as to what these lesions look like. So you probably see some of these in the MRI scan reports that come back to you. So this is a bank cart tear, effectively again looking at the shoulder from the top down. This is the humeral head here, this is the glenoid, and this lesion here underneath the bumper in front of the joint is a bank cart tear. So effectively what it is the rubber washer on the outside of the joint has been disrupted in front. So if you're looking at it from the side, this is a side-on view of the glenoid taking the humeral head away. So this here is the defect between the labrum in front of the glenohumeral, in front of the glenoid and the glenoid bone, okay? So that's what a Bankart tear is. So at arthroscopy, when we look into the joint, what we see is that if normal labrum looks something like this, where there's a nice attachment of the labrum to the glenoid articular margin, where you have a defect here between the labrum and the articular margin, that's what a Bankart tear looks like. And sometimes that labrum can actually fall off the edge, and so you have what's known as the cliff sign here, and so that's what a labral tear looks like. Reconstruction of this can be done open or arthroscopic. I suppose by choice I do these arthroscopically, but there are open techniques to do it as well. But effectively what you're trying to do is to pass a suture around the defective tissue and to dock that into the bone using an anchor. By and large, that's what the technique involves. There are several different fine-tuning techniques around it, but that's what the operation involves. Some of you may have come across Hill-Sachs lesions. So what a Hill-Sachs lesion effectively is a divot in the back of the humeral head. So for those golfers in you, the divot, I certainly not very good at making divots, so I don't get any backspin in my ball, but this is what the divot looks like here at the back of the humeral head. This is an axial view of the shoulder with the humeral head sitting out in front, the glenoid sitting behind. And what happens is as the humeral head dislocates, it impacts on the front of the glenoid and causes this big divot to occur in the back of the joint. So it's an impaction really rather than a chip divot, you might say. This is what it can look like on a CT scan. Again, this is the glenoid in the humeral head and the big divot at the back here, okay? So the options for dealing with that are myriad, and again, it's a difficult problem, so there are several different techniques. One of the techniques to deal with it is to fill the gap with soft tissue at the back, and this is known as a remplissage. So when you see that coming back to you on your post-op consultation letter, that's what a remplissage is. It's effectively trying to render the defect in the back of the humeral head extra articular. So it's by filling it with the soft tissue, the capsule, and a little bit of infraspinatus tendon at the back. And so what we do arthroscopically for that is we put an anchor into the back of the bone here with sutures that come out through the capsule at the back of the joint. So this is the glenoid, this is the humeral head with the anchor in it. Those sutures come back out through the back of the capsule, and then the capsule gets pulled into the defect. So a bony Bankart lesion as well, you might have heard of, and effectively that's just like a soft tissue Bankart but with a piece of bone missing. And again, the solution for that is to replace that bone that's missing and in the process create a muscle sling in front. So for those of you that may have come across patients who've had a Latarjet procedure, this is what a Latarjet is. So effectively what you're talking about is moving the coracoid bone from where it belongs up here down into the front of the glenoid, and that creates both a replacement of the bone block here in front, but in addition creates a muscle sling between the conjoint tendon and the subscapularis, and that is an active structure to push the glenohumeral joint into reduction as you elevate your arm. So that's what the Latarjet is. So that's just a quick synopsis of the techniques that are out there for instability. Again, I guess like in primary practice, if somebody has recurrent instability and they're still attending you with the instability, they probably require a surgical referral. And what I usually say is the patient that decides whether or not they need an operation, and really the imaging decides what operation is going to be. And those of us in shoulder practice will routinely do all of these procedures. Open, arthroscopic and Latarjet procedures are fairly common in most shoulder surgeons' practice these days, and it's really more, I suppose, the evolution of instability surgery has become much more a la carte depending on the type of pathology that's involved. So arthritis, as I say, this here, the difference, just to show you the difference between the two most common causes of arthritis, this one here is glenohumeral arthritis with a large osteophyte down here, well maintained space between the acromion and the humeral head. And this one here is rotator cuff arthropathy, which we've talked about already with the rotator cuff disease, where effectively because of poor control of the fulcrum inside the joint, the humeral head tends to elevate more and more and more as the disease process progresses. So there are lots of different options for arthroplasty in the shoulder, and it's really more about the soft tissue balances around the shoulder that these different techniques have developed. So you have total shoulder replacement here with the glenoid replacement on the inside and a stem component down here. You can have resurfacing total shoulder. You can have hemiarthroplasties for fracture, and this one down here we'll talk about in a minute. Oops. Yeah, is a reverse shoulder replacement. So, and that really relates to poor soft tissue, patients who have poor soft tissue, poor rotator cuff around their arthritis. So reverse shoulder arthroplasty, I suppose, has evolved from anatomic total shoulder arthroplasty. Anatomic total shoulder replacement works well for degenerative conditions, rheumatoid disease, avascular necrosis, but it requires a functioning cuff. So in patients who don't have a functioning cuff and good soft tissue balance, a reverse arthroplasty, which you can see here, effectively you are changing the orientation of the glenohumeral joint, moving the ball from the outside to the inside of the joint effectively. And what that means is that where you need rotator cuff function in the anatomic replacement, in a reverse, all you need is your deltoid, because the device is more stable in that configuration and requires only the deltoid for function in terms of motor. So that's the difference between a reverse and an anatomic. So I guess just more in terms of common conditions, we'll talk very briefly. I'll be finished in about 2 minutes, so I'm running over slightly. The capsulitis is effectively an inflammatory condition. 40% of the time, it is idiopathic, no cause for it whatsoever. The patient just comes in, they'll have had gradual onset of shoulder pain, which is probably the most painful condition that we see. These patients are often miserable, they're grey, they haven't slept for weeks because of their shoulder pain, and they'll say, I don't know why this happened to me. I wasn't doing anything different. Maybe they were doing a little bit more work in the garden, but no specific trauma, and suddenly the shoulder gets inflamed like this, and it's really, really painful. But the good news is that the vast majority of the time, by the time they attend you, they're already starting to get better. And the natural history of capsulitis is that it will go away, but sadly, it can take 2 years to get there, and some people are left with residual stiffness. So most of what we do in terms of intervention on the surgical side is to try and shorten that inflammatory phase so they get less stiffness and can start their rehab earlier. All right, but it's very, very uncommon for people with capsulitis to come to surgery. In the past, we used to do manipulations, which have fallen out of favor to a large degree. These days, if people come to surgery, it's usually an arthroscopic release if they've failed the injection, physiotherapy, and hydrodilatation route. So hydrodilatation is basically a large volume injection to try and inflate the joint and effectively open it up. But I suppose the number of patients that come to surgery are very, very low. And if they do come to surgery, the vast majority of those that do are diabetic, because the diabetic conditions, this is a diabetic capsulitis here, this one. So you can see how thick, this is normal rotator interval here, so you can clearly see the muscles, subscapularis, biceps tendon, and the humeral head. And this is a diabetic capsulitis, and this is the subscap underneath here. So you can see how thick that capsule is. So that's what capsulitis is, and you can imagine exactly why these patients can't move their arm, because that's so thick and so scarred. So for bursitis and impingement, again, I would consider this to be, to a large degree, a rehab problem. So basically, these patients will largely do well with injections and physiotherapy. The physio, and again, Darren can go through that with you, but in general, it revolves around trying to strengthen their cuff and also get some work hardening into their cuff, but also to improve their shoulder blade posture, their scapular posture, because a protracted posture tends to dynamically close the subacromial space and leads to further problems with impingement. So surgery for this condition, I would say, is relatively rare. Again, something in the order of maybe 5 in 100 that attend with this. There's been a lot of furore in the shoulder world about a recent study, which some of you might have come across because it was in the Lancet and also quoted in several generic newspapers, called a Seesaw trial. Effectively, unfortunately, it was a little bit misrepresented that basically shoulder arthroscopy didn't work for anything, which is patently not the case. But what this trial was looking at is subacromial pain and arthroscopic surgery. They took all comers, though, not people who had already been through a controlled physiotherapy program, and so it's a little bit, it's caused a little bit of furore, particularly in the UK, but it may have filtered over here. But I can assure you that arthroscopic shoulder surgery does work. It's just that it's not commonly needed for bursitis and impingement. Most people will do fine with injections and physiotherapy. And again, the role of the injection here is not necessarily to deal with the problem definitively. It's to give the patient an opportunity to do their rehab, and it's really the rehab that fixes the problem. Injections we'll go through briefly, I suppose, just to mention. Image-guided injections are certainly required for many injections around the shoulder, but in my view, subacromial and interarticular injections are possible to do blind. The important thing to do is to make sure that the flow from the needle is not impeded. Otherwise, you're probably injecting into a muscle or onto a bone rather than into the spaces that we're looking at here. But certainly, subacromial and interarticular injections are possible to do in the office, and I'd encourage you, if you can, to do a course on injections for primary primary care, as it's very, very satisfying, particularly for capsulitic patients who come into you. You can inject them on the spot and they will respond almost immediately. They'll be sleeping better that night. Okay, so it is a very useful tool. So I guess it's time for questions. Anybody have anything they want particularly to ask? Go ahead.
Hi, I thought if you had a frozen shoulder, capsulitis, that an ordinary subacromial or bursitis injection, just behind the shoulder, wouldn't help in any way. We were told before that.
Yeah, no, a subacromial injection is unlikely to help them. Yeah, correct. But an intra-articular injection would.
But as a GP, can we do an intra-articular injection? I thought you'd need fluoroscopic or ultrasound control.
No, again, in my view, glenohumeral and subacromial injections are both doable blind. I don't think you don't need to do it on an image. I think what's important is that you're shown how to do it. And that's actually something myself and Emer have been talking about before, that we'll probably run another day where we might do an injection workshop to show you how to do those.
Okay,
but I know that in the college as well, in the College of Surgeons, there's also as part of the GP training program, there is an injection module in it, because I get GP trainees that come to me in my injection clinic in Tala, and they do an injection module with us to learn how to do injections correctly intra-articularly. And glenohumeral injections and subacromial injections can be done. Now, I guess if you're not comfortable doing them and you want to send them to a radiologist or send them to us as the surgeons to do them, then by all means do. But it is possible to do it. Yeah. And like for capsulitis, an intra-articular injection really will work wonders for the patient. It may not eradicate their pain completely the first time, but it'll definitely improve it.
Just a comment before when you spoke first of all, talked about clinical examination. I think it's terribly important that you should examine the neck first. And I think this is something that a lot of people don't do.
Yeah, no, I'd agree. I think that
this is the commonest cause, particularly if the pain is worse first thing in the morning, if they've got a bad pillow or sleep on the wrong way.
Yeah, I think there's two elements to that. One is when you're examining somebody's shoulder, in inverted commas, people often forget to examine the neck, and the neck is definitely part of the clinical exam for the shoulder. And as you say, it's often a good idea to do that first so that you don't forget it, number one. That's absolutely the case. But in addition, a lot of people that come in with shoulder pain will report their pain posteriorly here, and it's often actually related to problems in their periscapular musculature rather than in the shoulder itself. And that'll be picked up on clinical exam of the neck rather than the shoulder itself. Exactly right, yeah.
I've had a reverse Copeland done on my shoulder many years ago,
Yeah.
so I know it takes a long time.
Oh yeah, it takes a while to get there, yeah.
Thanks for your presentation. Could I ask a slightly tangential question? People who come in with clavicular fractures, particularly where they heal with shortening, is there something we should be doing to prophylactically to stabilize and strengthen their shoulder joints? Or is that a risk factor for further difficulties down the line?
So in terms of glenohumeral problems related to the rotator cuff, the glenohumeral joint, arthritis and that kind of stuff in the joint itself, there's no documented impact of clavicle fractures on that. However, what I would say is the patients that come back to me with malunions, or non-unions where they have clavicle fractures that either haven't healed or that have healed in a bad position, what tends to happen is because the relationship between the clavicle and the scapula is like an A-frame. When you have shortening in front from the clavicle fracture, which is the typical finding, they start to get pain in the interscapular area at the back. So what happens is they come in, they're complaining mostly of posterior shoulder pain. They often, if they've a non-union, they'll have pain at the non-union, fine. But if they've got a malunion, the pain is often not at the clavicle fracture or where the site of the clavicle fracture was itself. It's usually posteriorly. And so a lot of the time they can be rehabbed very well by working on their interscapular posture, by working on their rhomboids and by working on the serratus anterior in particular to try and pull the shoulder blade back and control that position. And they'll often improve their pain with that. But there are the odd patient where they have persistent problems related to a malunion and non-union that we have to do corrective osteotomies or fixation on. But I would say that's not common, you know. Most of the time people will tolerate, certainly the vast majority of clavicle fractures will heal with less than 2 centimeters of shortening, and if they do, they tend to be non-symptomatic. Yeah. No other questions? Will we go ahead with the panel? Yeah, it's Fintan, yeah. Yeah. Yeah.
Sorry, could you just wait a second because we can't hear you off the screen? I'll grab one here. It's behind you. Thanks.
As a non-shoulder surgeon. Thanks very much. But it was touched on there. Do you think, certainly in my experience in recent years, the trauma and post-traumatic issues with the shoulder is going to become a bigger part of your practice? Because patients, when I first started training, or we first started training, the 80-year-old who broke their proximal humerus were treated conservatively and they just lived with their stiff, sore shoulder. Do you see that becoming a bigger issue of your practice, them coming back and not being able to play golf or skydive?
Yeah, it already is a big issue in my practice. The bottom line is I deal with quite a lot of proximal humeral trauma in particular, and upper limb trauma generally, but the demographics have certainly dictated that a lot more of these fractures are attending, and as you say, because their demands are higher, they are often looking for a solution that doesn't yield just a shoulder that might be pain-free but doesn't move at all. And so there are, I suppose there's been a large evolution in the treatment options for these people as well, even over the time that we've trained together. So like you know, I think when we started out in training, the options around locking plate fixation, around reverse arthroplasty and good quality hemiarthroplasty for proximal humeral fractures in particular didn't really exist, or was certainly only in its infancy, and now that's become much more mainstream. And so patients' demands have increased with that as well. But all these, I would say, again, it's managing patient expectations in proximal humeral injury in particular is very, very important, because it's such a complex and dynamic joint with so many elements to it in terms of trying to maintain its mobility and its stability. I think, sadly, once you have sustained a significant injury to the shoulder, it's unlikely that the patient will get back to, you know, a pre-morbid situation. But you are often trying to deliver you know, a pain-free shoulder that has function to reach behind head and behind back, and then after that, then everything else is gravy, I would say. But there's certainly, because of patient demand, but also because of evolution of the technology, there definitely is an increase in the number of patients that require surgery for those conditions. Yeah, post-traumatic ones. Yeah.
But even from a GP perspective, patients who turn up 6 months or a year after their fracture and we're told that it's fine, do you think it's reasonable to be sending them on to a specialist shoulder surgeon for potential arthroplasty surgery?
Yeah, I think like all these things, if the patient is unhappy, the line is like, listen, this is the best we can do. If your treatment plan or your treatment algorithm doesn't go all the way to joint replacement, then I probably would refer them to somebody who has that, because you will know whether or not you'll be able to improve the patient's lot through intervening surgically. So I think if you have a patient who is unhappy with their situation following a traumatic event, I would definitely refer them on. Yeah, and the big one is patients who have large rotator cuff tears that may not have been picked up. They attended the A&E department. They had an X-ray done. The X-ray shows that everything is normal, but they never had soft tissue imaging, and yet they have really poor function. They keep attending a clinic going, I still have pain, I can't move my arm. Definitely send those patients on, because there's almost certainly something you can do for them. Yeah.
Just a comment that I'm seeing more people with osteoporosis who've had humeral fractures, and you know, they don't heal because they have to find out the cause of the osteoporosis and treat that. So just a comment, we're getting more and more, and in much younger people as well.
Yeah,
not just the 80-year-olds.
Yeah, sure, absolutely. Yeah, I'd agree with that. I guess the fracture patterns that we see, like all things, there's a bimodal distribution around fractures in the proximal humerus or in the upper limb in general. You have the young people who have very high energy injuries, and you have the older people, osteoporotic people, who have less high energy injuries, but nonetheless very bad fracture patterns that the outcomes clinically from are really poor. And so there certainly is a change in the demographic there, no doubt. Yeah. Okay. So, Darren, did you want to add anything in from a rehab perspective, or? So this is Darren Nash, by the way. She's one of our senior physiotherapists. So.
I suppose just going back to your question about the clavicle earlier, we often see those people 6-12 months later, and they're coming in with some other form of shoulder pain, be it rotator cuff type related pain or bicipital pain, and generally it's because they were immobilized for their clavicle fracture, but there was very little rehab afterwards. So they've just gotten quite generally weak around that shoulder girdle, and the rotator cuff has just become quite deconditioned. And then sometimes it might not be, so Diarmuid talked about the humeral head moving capitably in that glenoid fossa, but from a tear point of view, but sometimes it could just be from a slight dysfunction of that rotator cuff, and with physio we focus a lot on getting that humeral head back down, getting them more stable around that scapula, and just getting the whole thing functioning a little bit better. And I suppose from a rehab point of view, as you said, Diarmuid, it's very, it's not a quick fix, and it is very important to reiterate to patients at the start that this is not a passive approach. You will not, if they're just having conservative treatment, you will not feel better after 2 to 3 hands-on physio sessions, and it is very much they're going to have to do the work. It won't be a linear improvement generally, it'll be a little bit up and down. But as you said, in 6 weeks, we'll generally know if they're going to respond to conservative treatment on its own, or do we need to refer onwards. Really.
Yeah. In addition, we'll go through some exam techniques shortly, but the other thing to look out for is there's the deconditioned cuff, the deconditioned kinetic movement around the shoulder. But in addition, patients can often, so I've said capsulitis is idiopathic in 40% of cases, but capsulitis is post-traumatic in the other 60%. So in the end, you can have people that have relatively minor injuries to the shoulder or even more significant injuries to the shoulder who just develop a really nasty frozen shoulder post-operatively, and identifying that and dealing with that is important. And that's back to Fintan's question as well, is that often patients will come in with a post-traumatic stiffness in their shoulder and all they really need is a release, and that might actually move them on. So identifying post-traumatic frozen shoulder is also important in the post-traumatic patient, and that's often something that will turn up in a primary care practice, no doubt, be it at a physiotherapy level or at a GP level for sure. So we talked maybe earlier on about maybe just showing a few exam techniques, so if you don't mind being the model there, and that would be great. Apparently we have to stand over here for that. So will you give me the flag at 10 minutes? Yeah. So that's where we are now. Yeah, okay. Yeah. Cool.
There's some great feedback coming from
a little bit this way.
Audience,
yeah.
so that's
Cool.
great. Just while you're getting going, there's 2 questions that have come through in regards to the reverse shoulder replacement, in regards to patient expectations, what they should be expecting following this sort of procedure, and sort of what the recovery process is.
Yeah, that's a very common issue, and so I suppose around reverse shoulder replacement, it has been effectively a salvage procedure for people who previously had very poor options in terms of massive cuff disease or associated rotator cuff arthropathy. And so what we know is that when we look at people, if you stratify them post-operatively into the unhappy, the kind of meh, or sort of not really that much different, a little bit happy, and really happy. The really happy people are the ones that didn't have elevation to 90 degrees preoperatively. And so if your patient preoperatively doesn't have elevation to 90 degrees, you need to be very careful about selecting them for surgery, because post-operative they may not, because the devices are mechanically limited. If the patient has a lot of residual posterior rotator cuff disease, they won't be able to externally rotate so well unless you do fancy tendon transfers and stuff, which we do to try and ameliorate that problem. But the outcomes in those patients, in terms of their patient satisfaction, if they can preoperatively elevate to above 90 degrees, are not as good as the ones that can elevate less than 90 degrees preoperatively. The other thing is that the primary goal of all arthroplasty, be it from the knee or the hip, is always pain control. And so the biggest predictor of post-operative function for arthroplasty in all comers and also in the shoulder is your preoperative function. So while you can hope, because of tendon releases and soft tissue releases around the shoulder, that you can make some improvements, because those muscles haven't had that excursion for possibly several years, you may not be able to retrieve that range of motion for them. But I would say that reverse arthroplasty is an excellent tool for dealing with a problem which we previously didn't have a solution for, but it's important that the patients are carefully selected, would be my feeling on it. Some people do really, really well, they get great elevation, but because of the mechanical limitation around the reverse arthroplasty, you can't always promise them that. An anatomic shoulder replacement has an excellent range of motion. there's no restriction in it. It's a true ball and socket range of motion, but for assuming that their soft tissues recover appropriately. But a reverse does have some mechanical limitations. So again, their range of motion may not be what they hope for, and it's important that they're counselled accordingly. But having said that, I think reverse shoulder replacement has absolutely revolutionised our treatment of massive cuff disease in older people. It's fantastic too. Yeah.
And then the other question, maybe it's more pitched towards Duran, would be in regards to like a rotator cuff injury coming in, and you mentioned before how you need to have the 3 months of physio rehab. There's physio and there's physio. What should be done? What does physio involve for that initial stage of rehab for a rotator cuff injury? Yeah.
Well, I suppose a lot of it is based, it is a treat what you see. So what the typical presentation was that we'll have lost range of movement, obviously more active, sometimes more passive because they just haven't been going into those ranges for a while. So pain control initially, so isometrics, so your static holds are often quite useful. Passively getting them back into those ranges and active assisted ranges of movement at home as exercise program. And then the big part of it is you're going to load that cuff gradually, but it has to be a very progressive, well thought out and well judged program, or all you're going to do is send their pain through the roof and send them backwards. And it's a little bit, it's individual, and it is long. It's certainly 12 weeks. I'll generally tell people 3 months before we're going to make a decent impact on this. But it's loading. It's all loading. We'll talk some about lifestyle factors as well. We know things like smoking and stress and all the rest will impact on it. But it's predominantly loading, getting the thoracic spine moving and getting their scapula more stable, basically.
Thank you. So did you want to show the
yeah, so I guess a lot of the time you have patients that come into your clinic, they'll be very, very sore, and in obviously examining any joint that's very sore, and the classic example is somebody with a frozen shoulder with an adhesive capsulitis. But they'll be very sore, and you'll say, God, how can I examine this person? How can I determine whether or not they have an associated cuff problem? So if somebody comes in, and it's like I said, this time of year, it's the typical, just starting the lawnmower for the first time in 6 months, and they feel something go in their shoulder, and now they can't move it. So how do you determine, is their cuff actually okay, or is this just a frozen shoulder that's being triggered? So there's some very easy techniques for this. We've already mentioned that it's important to examine the patient's neck for starters, and I would always do that at the beginning of a shoulder exam, because otherwise I will certainly myself forget it. So it's important to examine the patient's neck, but taking that aside, just in terms of the actual rotator cuff itself. So I'll just get you to turn the face towards me, maybe, Darren. That'd be great. So just tuck your 2 elbows in like this. So if the patient's very sore, they may not have much in the way of active range. So we'll come to active versus passive range in a minute. But just from the cuff itself, stay strong in this position here. I'm going to push this way. So just push against me. All right, so that's your posterior rotator cuff, so your teres minor and your infraspinatus. In this position, predominantly infraspinatus, but it does fire both. Next thing is put your hand on your tummy and bring your elbows forward. I want you to fall in on top of me now. So that's your subscapularis, so it is resisting. So it's an internal rotation movement that the patient is doing. And the last one is just straighten your 2 arms out like this and bring them slightly forward for me. And I'm going to push down this way, just push up against me. So that's your supraspinatus. And effectively, the patient hasn't had to move their arm that much to do the test. If somebody's capsulitic, they'll find it very hard to move out here to do your impingement signs, or they'll find it hard to reach behind their back to do a Gerber's liftoff test. But if you just do the Napoleon belly press, your Job's test with the arm out low like that, and resisted external rotation, they haven't had to move their arm that much to identify whether or not their cuff is intact. And it's a very quick screening tool to do that in somebody who's got bad capsulitis. In somebody who has, comes into you and says, I can't lift my arm, the thing you want to determine is this a motor problem or is this a stiffness problem? That's what you're looking for. So they come in and say, I can't move my arm, right? I can only get it as far as here. You want to know, is it that because their muscles are deficient or because the joint is stiff? And the quickest way to do that, so if I say to you, like, so you're going to have full range of motion, thankfully, so just bring your arms up over your head. So that's a composite motion, right? So that's happening both in the leniohumeral joint, but also in the joint between the scapula and the thoracic cage, all right? But in somebody that comes up to this position here, they can't elevate their arm fully on one arm. You've got to determine, where is that lack of range happening? Okay, so they may have a muscle deficit, which you've just been through there and testing the rotator cuff. If they're weak, obviously, then you're thinking this is a muscle problem. But you also need to identify whether or not they're going to have a stiffness in the joint. So if you can spin around and just face towards Chris there for a second, just spin all the way around. So basically, I'm going to stand close to you just for a second. Just tuck your 2 elbows in, okay? So what this does is when the elbows are close to the side, it means that what we're dealing with now is only glenohumeral range, all right? So as I externally rotate here, that's glenohumeral range. The scapula is not really involved in the motion here at the moment. So if somebody's capsulitic, they'll only get as far as here, and at the end of that range, they'll be really sore. And so that's how you would make a diagnosis. Okay, this person's lack of range is probably related to capsulitis. If they have an arthritic problem, they'll also have limitation in range, but they'll probably have pain and crepitus all the way through. Okay? And that restriction in the glenohumeral joint can be picked up very easily like this. And again, you don't have to hurt the patient or have to have huge range of motion to determine it. So I think that's a useful way of doing that. In addition, you can check for range of motion limitation and abduction by supporting the top of the scapula here and bringing the arm up into this position. Okay, or to keep it in that position and internally rotate for posterior capsular tightness. So for lack of range problems, that's how you'll pick up, is this the capsule or is this a lack of motor, okay? The other ones I suppose to look for very briefly, seeing as we're in this position here, is you'll be testing for impingement signs. Okay, so other common cause of shoulder pain is obviously subacromial impingement. And so typically, if you're testing for the rotator cuff, try and test for it down low, because if you do that, then you're not going to mix up whether or not this person has impingement or whether this is a true rotator cuff problem. But impingement is usually in the mid-zone here. So as they come into abduction, they'll catch their greater tuberosity underneath the acromion of the shoulder. And in this position here, if you just move them just subtly into increase their abduction and supporting their scapula at the same time, you'll impact that and generate their pain. In addition, what you can do is you can internally rotate in that position to really bring the rotator cuff underneath the subacromial space. And again, that causes an increase in the irritation, identifying subacromial impingement or bursitis, okay? And then very briefly, I'll just get you to turn back towards me again. After that, for simple things like AC joint pathology and biceps problems, you've got to just poke the patient, effectively poke them in the spot that's sore. So if the patient has AC joint pathology, they'll often be tender over the AC joint. If they have biceps pathology outside the joint, they'll often be sore here. All right in the bicipital groove. And some people have a groove that's a little bit hidden because of rotation in the joint. So just keep your thumb on the groove and just move the arm over and back, and they'll often be sore in that area there. Okay. And the last one you'll often come across reports of an MRI that says this patient has a slap tear or a superior labral tear. Okay, and the way that's effectively an extension of a biceps problem, because the superior labrum is the anchor of the biceps of the long-headed biceps inside the joint. So if you put your 2 hands in front of you like this, just bring them up in front there. So if the tear is a little bit at the back of that, just push up against me. The patient will be weak. If it's a little bit across the top, they'll often be sore and weak in this position here. They won't be able to maintain the position as they come to here. If you bring the arm across the chest a little bit, and again, just resist me as I push down, they'll get pain generated inside the shoulder. So it's important to differentiate where are you feeling the pain. And I suppose for most exam techniques, you're going to be asking that, where are you feeling the pain? So if they feel it up here in the AC joint, it might be just the AC joint is the problem. But if they feel it deep inside the joint, it might be the origin of the biceps tendon as well. And that's called an O'Brien's test, which can be useful for that. Okay. So instability testing, I guess, again, in a 20-year-old person that comes in the door, even if they're reporting pain rather than instability, the first thing you should be thinking is this patient is unstable. So examining them for instability is pretty straightforward. I suppose in my clinic, I tend to examine these people a lot of the time sitting down, but it's often easier to do it lying down. So if you are used to examining people for instability lying down, then go ahead and do that. But I'll just move this to here, and I'm going to stand beside you. So if you sit on the chair there. So again, for instability, usually the patient will be most uncomfortable in this position here. So what I'm doing here is I'm just going to support their scapula. My thumb is in the soft spot at the back of the glenohumeral joint, and I'm going to bring the arm into further external rotation. So the patient will just say, oh, I don't like that. That's apprehension. If you then bring the arm slightly forward to release that, press the front of the joint. So keeping your thumb in the back of the acromion here, and press the front of the joint and bring them back into that same position, they should feel more comfortable. I'm now pressing with my fingers on the front of the deltoid here to try and push the humeral head back into the joint, and the patient, if they're unstable, should feel a little bit more comfortable when you do that. Again, it's probably easier if you're used to it to do that with the patient lying down, because you can actually lean on the front of their glenohumeral joint. Okay, so for instability testing, they'd be the basic test for that. Okay, any other tests that you would like me to demonstrate or that you have any burning questions about? No. Are we out of time, let's say, at this stage anyway, are we?
Good.
Yeah, okay. Thanks very much. Okay.
Thanks so much, Diarmaid and Darren. Thanks, that was brilliant. Thank you.
Thanks, mate. Cheers.
That was great. Thank you very much. So next we have Professor John Quinlan. He's a consultant orthopaedic and trauma surgeon. John works out of Blackrock, obviously, and Talbot Hospital. He's special interest at primary and revision total hip and knee replacement surgery, as well as soft tissue surgery. He completed his fellowship in lower limb arthroplasty in New Zealand. So I'm sorry for that, having to do that through New Zealand now, John. But anyway, over to you, and thank you.
Oh, sorry. Thanks very much indeed. A little bit difficult to follow that tour de force by Dermot. What I'm going to do is hopefully run through the next 25-30 minutes, just run through a lot of the common questions that patients who are having hip and knee replacement ask, and try and provide really simple answers for a lot of questions that you'll be asked in your clinics and we're asked in ours. And a lot of this goes towards alleviating the fears that patients have, because there's no doubt a patient who is comfortable with the decision they've made to come forward for surgery gets better and gets better faster. And it's amazing some of the unhappy patients, when you dig down into their unhappiness later on, it often revolves around one or two unresolved issues or unresolved questions that nobody really sat down and explained to them. So similar to the exploding shoulder world, if you look, these are the 2011 census figures projected out to 2036, which seems like a long time away, but unfortunately I'll still be working unless I win the lottery. There's a lot of figures there for a Saturday morning, so we will summarise. By 2021, which is not very far away, the amount of people in this country who are over 65 will have gone up by 50% compared to 2011. By 2036, they'll have gone up by 100%. The over 75s will have gone up by 50%, but by 2036, they'll have gone up 150%. And the key issue then is the over 85s will have gone up 50% by 2021, but by 2036 will have gone up 300%. And this is against a background of the total population increasing 8% by 2021 and only 13% by 2036. So we're going to have an awful lot of older patients around in the coming years. And as you all know from your own practices, these patients have increasing demands and they can't be fobbed off like perhaps we used to do when I was starting in orthopedics. The other concern obviously is where are all the young people going to come from to pay for me and the rest of you in our retirements. Look, how this manifests into primary lower limb arthroplasty, essentially it's still a condition of older patients. We've all had our young patients and we can give you anecdotes about all of them and how they end up being done at 20 years of age or 30 years of age, but in the majority of cases, older patients are having their hips and their knees replaced. In the United States, there's about 400,000 hips done a year. There's about 1 million knees done a year in the United States. It's really enormous business, and if you ever go to any of the North American meetings, you are absolutely blown away by the commercial aspect of this type of surgery. In the UK, there's about 100,000 odd hips and knees done each year. We think in Ireland there's about 15,000 done a year. We don't really know. We're in the process of setting up a joint register. The process of setting up the joint register here is in about its 23rd year, so I wouldn't expect any immediate outcome from that. Of the 15,000, it's about half done in the public sector and half done in the private sector. This is a paper from a couple of years ago where the Americans projected their workload, and if you look at the figures, even from 2010 to 2020, hips are doubling, knees are doubling. Those of us who are doing revisions will see our hip revision practice go up by about 50% and our knee revision practice go up by 50%. So there's no doubt there is a deluge of lower limb arthroplasty coming down the road for our patients and for ourselves. Happily, in terms of evaluating these patients, it's very, very straightforward. We don't have as many alphabets as the shoulder surgeons have, but the same tenet applies to hip and knee surgery. A hip replacement and a knee replacement is offered to a patient in severe pain that is refractory to conservative measures. The indication is always pain, and that's what you want to get in the history from these patients. Now, patients will come into you and they'll talk to you, tell you that they have hip pain, and if you push them a little bit, the vast majority of them, and I would include myself in this, don't actually know where their hip is. So in reality, what the three pains they talk about are groin pain, buttock pain, and referred knee pain. And even then, you need to spend a little bit of time with them, because it's amazing how many patients come into you and you say to them, have you any pain in the groin? They go, no, I've none at all. And then you say, have you any pain there? They say, I do, that's exactly the pain I have. Then you ask them about buttock pain. No, I have no buttock pain. Do you ever get a pain like someone's giving you a kick in the backside? I do. That's the pain I have. Yeah. And then you ask them, have they any knee pain? No. And then you get your finger and say, do you ever get a pain down the leg like that? Yes, I do. So if they've groin pain, buttock pain, and referred knee pain, you can be pretty sure they've hip arthritis. And the hip pain, in inverted commas, is never mentioned. The referred knee pain can go down to the pretibial area, the immediate pretibial area, but no lower if it's coming from the hip. Similarly with the knee, the vast majority of knee osteoarthritis we operate on is in the medial compartment, and most patients will be quite specific that it's medial pain. Again, they will, when you ask them where's the pain, they'll say the pain is in my knee, and then you say, can you point with one finger, and they will quite reliably point to the medial aspect of their knee. A small percentage will be valgus osteoarthritis causing lateral pain. Patellofemoral joint arthritis we would see a lot of, either in isolation or in combination with the medial compartment, and that will give them anterior knee pain. And they're the patients who classically struggle with stairs, they struggle with squatting. If they're kind of at the lowest shelf in the kitchen, they can't get themselves up. They'll also get a bit of pretibial pain. It is essential that you check and ask patients about lower back pain, because clearly lower back pain can be the cause of their problem. Also, lower back pain can coexist with an osteoarthritic hip or an osteoarthritic knee. Doesn't mean you can't replace the hip or replace the knee, but you just need to set realistic expectations for the patient. If a patient has a very sore hip and a very sore back, you can probably sort their hip out, but their back pain will be exactly the same the day after surgery. And certainly any pain that is radiating or seems to be referred down towards the distal lower limb, towards the ankle, towards the foot, invariably it's a local cause or it's coming from their back. So certainly beware of any of those patients. That is not a pattern of pain that fits with typical hip or knee osteoarthritis. Function. This is what apart from the pain, it's their function. And again, you're talking about older patients whose function gets severely limited. Again, walking is one. How far can you walk? I can walk 2 kilometers, and you look at the patient and think, oh, that's fine, I don't need to do anything for you. But then you tease it out a bit. So they can walk 2 kilometers, but they stop 9 times. So that's not actually walking 2 kilometers. Or they can't walk for 2 days afterwards because they're so sore, or they're limping all the way. Night pain. Again, be very clear what night pain is. Night pain is a pain that wakes them from their sleep. It's not the older guy who wakes up and needs to go to the loo, and as he's going to the loo notices that his hip is sore. Night pain, it's when the hip pain wakes him up. And invariably then, seeing as he's awake, he might as well go to the loo. Stairs. Stairs is a big issue for patients, particularly patients in houses where the bathroom is upstairs, because they get to a stage where literally they plan toilet breaks during the day because it's so sore going up and down stairs. That's a pretty significant impact on someone. Putting on their shoes and socks becomes very, very difficult, particularly in respect of the hip arthritis, because they can't bend sufficiently. So a lot of them will be wearing slip-ons, a lot of them stop wearing socks, a lot of them have shoehorns, and a lot of them learn the most fantastic array of tricks to get around the problem. Toenails, they can't cut their toenails. An awful lot of them will end up with a chiropodist. Walking aids is most unusual in Irish culture. There seems to be a pride amongst Irish patients that no matter how bad they are, they will not use a walking stick or a crutch or a cane. And it is extraordinary how many patients you suggest, have you considered a walking stick? And they look at you as if you tried to eat their young. I have not quite worked out that concept, but anyway. And then the car. Getting in and out of the car becomes extremely difficult, particularly if the seats in the car are low. And again, if you're talking about older patients, perhaps they're living on their own, their only outlet is to go to the shops, go to mass, go to bingo, go down to play bridge, etc. They stop going because it is so sore getting in and out of the car, it's just not worth their effort. And all of this adds up to a significant impact on their quality of life. The quality of life, it's really important to remember, this is patient specific. So you might get a patient who comes in and says, I can't play golf twice a week like I used to. And you think, tough luck. That might be the only 2 times that the patient leaves the house in the week. So it is very relevant. You know, they can't garden anymore. That might be their, should we say, their mental health moment during the week. So the quality of life is quite patient specific. And again, as you go through a history with a patient, it's amazing how many of them, by the time they get it all off their chest, will tell you pretty much straight up, I don't enjoy life anymore. My quality of life is affected. I feel old. I shouldn't be. I'm 72 or I'm 74, and I feel much older than that. In terms of past history, we don't need a comprehensive past history. We don't need to know everything about them, but there are some particular relevant past history issues. So past surgical history, Things like childhood hip conditions. Did they have childhood hip conditions? Did they have surgery for childhood hip conditions? Because if you're not prepared for that, that can certainly give you a nasty little surprise when you're in the middle of theatre. In respect to the knee, have they had an ACL reconstruction? Have they had a unicompartmental knee done? Have they had arthroscopies? Have they had meniscectomies? Of particular relevance, have they had any anaesthetic reactions to any previous surgery they've had? In terms of past medical history, again, we're all taught in medical school to take these wonderful florid histories. Really, it's the relevant bits we need. So, for example, have they rheumatoid arthritis? The relevance to the rheumatoid is some of the medications they're on can play absolute havoc with wound healing. So that's very important. Have they diabetes? So they're at risk of everything, really, if they have diabetes. Have they any past history of infections? Do they ever have any surgical infections? Have they MRSA? Have they CPE? Have they VRE? Have they ESBL? And all of these new bugs that seem to be invented, about 2 new bugs a year. Medications. So the really important ones are steroids because it affects wound healing. The disease-modifying agents that the rheumatologists use. Anticoagulants. Again, there seems to be a new anticoagulant on the market every 6 months. Each one seems to be completely different to the ones that have gone before it. So they all require management in the perioperative period. In terms of examination, it's pretty basic. So BMI is a huge topic of controversy in the lower limb arthroplasty world. Again, this is a big, big deal in North America for 2 reasons. One, they are all enormous over there. And 2, the funding model in the United States. If a patient is readmitted within 28 days, they have a very significant financial penalty. So a lot of the big institutions in the States just don't operate on fat people anymore. Or what a lot of them have is essentially an in-house bariatric surgical service. Problem with that is there's plenty of literature out there. Patients who lose weight before hips and knees, they all put it back on afterwards. So whilst they slim down in time to get their hip or knee done, all the weight comes back on afterwards. Obviously, a cardiorespiratory examination, I'm not going to profess to bringing a stethoscope to the clinic myself, but it's probably ideal if someone listens to their heart and their lungs. If their heart won't withstand surgery, there's no point in putting in a nice hip and then ringing the mortician. Similarly with their lungs. Skin is essential. The biggest enemy we have in lower limb arthroplasty and indeed upper limb arthroplasty is infection. So if there's any suggestion in the skin that this patient may not be suitable for an operation or that this patient may be at higher risk for infection, you just need to put the brakes on. So any persistent distal ulceration, maybe they need to be seen by the public health nurse or the vascular surgeon. Psoriasis. It's only recently I discovered that under each scale in psoriasis there's bacteria. So if there's any psoriasis anywhere near the wound, we will run a mile. In terms of examination, it's even simpler than the history, thank God. You look at them walk. So there are multiple textbooks written about gait. I have read none of them and I don't intend reading them. But the 2 gaits that you will see in a patient with hip arthritis is your classic antalgic gait, away from pain. And this is no matter, the example I would give in a room here, we're tall, we're small, we've men, we've women, we're all completely different in this room. If I go around and kick every single one of you in the shin, you will all limp exactly the same way. So your antalgic gait is the classic, it's the footballer coming off the pitch. Trendelenburg is the waddle, or the old man's waddle, and that usually relates to an abductor dysfunction. Again, if they have a very profound Trendelenburg gait pre-op, you would be a little bit concerned about their abductor function, which may impact on their ability to get good value from their hip replacement. Their range of movement. It is amazing how reduced some patients can be by the time they actually get to a clinic, particularly internal rotation. An awful lot of patients by the time they're seen actually have no internal rotation at all. And examining internal rotation is invariably the sorest of the movements to check. The skin, we've mentioned. Distal neurovascular function. Again, any leg that is frankly neurologically dysfunctional, you would be very, very slow about doing a hip or a knee, because a lot of the risks attached to that surgery are amplified if the nerves aren't working properly. Always check the patient's greater trochanter, because again, patients, particularly patients who are a little bit vague with their history, a lot of them actually really only have trochanteric bursitis, and they will have pinpoint tenderness right over their trochanter. And if you really want to get them, put them on their side, get them to lift their leg, and when they lift their leg and then you press them, that will really, really hurt them. And you will certainly pick out a tranche of patients who, when you've done that, they'll say, actually, that is my pain. And the other classic in the history with the trochanteric bursitis patients is when they lie on that side, it's extremely sore. So they can walk, but they're sore after walking. They can go up and down stairs, but they're sore after it. And when they roll onto that side, it's very, very sore. A lot of those patients can be managed with physiotherapy and or injections. Don't ever need to be seen by any surgeon, and certainly don't need surgery. There are some procedures described for trochanteric bursitis, but they pretty much to a man do not work. In terms of knee examination, again, it's extremely straightforward. Again, in bold capitals at the bottom of the slide, and I didn't correct the slide during Diarmaid's talk, you start with the hip, and always start with the hip because you'll forget the hip if you do the knee first. And again, the reason you start with the hip is because you can get knee pain referred from the hip. And even patients, sometimes when you have florid hip arthritis on the x-ray, they still refuse to believe that it's not actually their knee. Again, you look at their gait, it's a classic antalgic gait. Sometimes they'll have this thrust, a varus thrust or a valgus thrust. Fixed flexion deformity is quite common in knee arthritis, probably something that none of us actually examine very closely, but a lot of them, when you press the patient, when they're completely relaxed and you press the leg right down, you should be unable to slide your hand in around the back of the knee. And again, when next time you have a patient in and you're pressing the hand down, you'd be amazed at how often you can slide the hand in easily. That would suggest there is a small degree of fixed flexion deformity. It's not really, a small degree of fixed flexion deformity is not enormously relevant in terms of technical management of these patients. What is relevant is their overall range of movement. And again, this would be exactly similar to what Diarmaid alluded to with the shoulders. The biggest single predictor of post-operative range of movement in knee replacement surgery is their preoperative range of movement. So whilst we will still operate on patients who have very, very diminished preoperative ranges, we would specifically counsel them that they may not get a fantastic post-operative range of movement. Collateral stability. If a patient has an inherently weak medial or lateral collateral ligament, that is of technical relevance because maybe the straightforward knees that we put into the vast majority of our patients is not appropriate. The skin is even more important in the knee because at least the hip is well buried, whereas your knee is immediately underneath your skin. So if there's any bugs hanging around the skin, they can get into the knee very fast. Distal neurovascular function, and in particular if there's any extensor mechanism dysfunction, again you would be very, very slow to rush in and do a knee replacement. In terms of investigations, it gets simpler again, thankfully. All we need with these patients is plain film x-rays. Now I have down at the bottom no role for CT or MRI. In 10 years I think I've had one CT and one MRI for a preoperative hip patient, not in the same patient, two patients. I am well aware of patients who come into your practice and no matter what you say to them, they want an MRI scan. The downside of that is they then come into us having shelled out 200 quid for their MRI and they hit the roof when we send them for an x-ray because they want to know, why can't you make a decision off my MRI? Now, you can on occasion, but the basic investigation for osteoarthritis and the basic investigation for technical planning of a hip or a knee replacement is a good old-fashioned plain film x-ray. But it is amazing how annoyed patients get when they get sent for a plain film x-ray, even though they were the ones who demanded the MRI from the GP in the first place. All we want is a proper AP pelvis and a lateral x-ray. There's the characteristic findings of osteoarthritis: decreased joint space, subchondral sclerosis, cyst formation, osteophyte formation. That's what osteoarthritis is on an x-ray. It gives us a little bit of information about leg lengths. Patients who have a significant leg length discrepancy before a hip replacement, you need to tell them that they will have a significant limb length discrepancy post hip replacement. Some of the DDH patients who are way up and have really massive discrepancies beforehand, you do your best to bring them down. But if you bring them down too far, if you bring them down more than 3 or certainly 4 centimetres, you will knock off their sciatic nerve. So you'd be much better off, certainly, maybe we might discuss this later on, in my opinion, you're much better off bringing them down 2.5 centimetres where it's completely safe, and just tell them, I'm not going to get this all the way down. And then occasionally in the more unusual cases, there are some technical considerations that can be picked up on the plain film x-rays. One word of caution, you'll all receive multiple reports back in your practice on x-rays showing mild osteoarthritis, moderate osteoarthritis, severe osteoarthritis. That's very much in the eye of the beholder. To my knowledge, there is no verified classification system on reading plain film x-rays of hip osteoarthritis. So beware the patient who's actually not that bad and then gets an x-ray saying severe osteoarthritic changes, because it doesn't necessarily correlate to what's going on with the patient. Two very straightforward examples. On your right is what one would regard as a fairly normal set of hips. You can see there's nice round femoral heads. There's, what's the pointer here? The red thing, I presume. Yeah. So you have nice round femoral heads. You have nice smooth acetabuli. and you have a nice space in between. So they're pretty much normal hips. I think you can appreciate here you do not have a round femoral head, you do not have a smooth acetabulum, and you have no joint space. And you also have osteophyte, and you also have cysts, and you have thickening of the white line here, which is subchondral sclerosis. So having just said there's no classification system, I would certainly regard that X-ray on the right as having severe osteoarthritic changes. In relation to the knee, again, and in fact, in terms of patient demand, knee MRIs is probably even greater than hip MRIs in general practice. And again, I know patients come into you, and until you fill out that MRI form, you have an unhappy patient. Again, then they come into us waving their little disc, and we send them for an X-ray, and they get very unhappy. All we want is a straightforward set of weight-bearing AP and lateral X-rays. We don't need anything else. When I was starting off, we were always taught that the patient on the first visit with knee arthritis should also have a set of hip X-rays done for completeness. It's kind of died out. The principle remains the same, but it is very difficult in this day and age of everything being regulated and EU directions on ionizing radiation and so on. It's very difficult to persuade any X-ray department in any hospital that that's actually good practice. So it makes an examination of the hip in the knee patient all the more relevant. Again, the findings are exactly the same. What you're looking for, this is not a normal knee, but it's more normal than the other one. You can see you have joint space there. You're losing some joint space laterally, but here you have no joint space at all. And if you look at the overall alignment of the limb, this has gone way out into valgus. Again, as I mentioned earlier, the valgus knee would be only a smaller percentage of what we do. The varus knee or the medial osteoarthritis is the main component of what we see. Again, on this lateral view, you can see some very significant subchondral sclerosis. That is probably a bare patella. It probably will look like marble when you open it. And then some fairly significant osteophyte formation there. So the first thing they want to know is, can anything go wrong? So if any patient ever asks you, can anything go wrong with my hip and knee? The answer is absolutely yes, it can. And anything that goes wrong with the hip and knee is catastrophic, because any patient who comes to you or comes to us for a hip or a knee replacement will have had brothers or sisters or mothers or fathers or loads of friends or people down the golf club who've had hips and they're back playing golf in 3 months. So they want to know, how could it possibly anything go wrong? Things do go wrong in hips and knees. And when things go wrong in hips and knees, it is an absolute catastrophe because the level of expectation is so high. So certainly I think it behoves us very much as the surgeons to be quite explicit with patients about the risks. So the 3 risks that would pertain to hips and knees would be the anaesthetic risks. Every single operation any of us do in any branch of surgery has a risk pertaining to the anaesthetic, like a heart attack, like a stroke, like dying. The figures are extraordinarily low, but those risks exist. Thromboembolic disease is another one that patients get very, very upset about. It is a fact of life in lower limb arthroplasty. We don't really know what the incidence of DVT is after a hip or a knee. If you search through the literature, you will get an incidence of anywhere between 4 and 70%. So if the range is that large, that would suggest to me that nobody really knows. What we do know is that the rate of fatal pulmonary embolus after a hip or a knee is about 1 in 2,000. And as I always tell patients, that's a very low figure, but it is a real figure. And I won't ask for a straw poll, but I'd be very surprised if any of us here haven't had a patient who that's happened to. What most of us do is, I'll talk about anticoagulation in a couple of slides' time. We do all use an anticoagulation program for patients. There is no evidence at all of any single agent anywhere in the literature that absolutely prevents the rate of fatal PE. The problem is that this is a massively litigious area. So certainly any surgeon who went in and operated on a patient and did nothing would be hanging in the breeze. And I would imagine your insurers and defense people would be running a mile if that happened. Infection, I've mentioned, is probably the single most catastrophic problem. Infection rate for hip is about 1 to 1.2%. For a knee, it's about 1.6 to 1.8%. Interestingly, when you go to the States now, to the meetings, they're all now starting to quote infection rates of about 2%. So clearly it is starting to just creep up a little bit. Again, the knee infection rate is higher because the knee is just basically closer to the skin and closer to bugs than the hip is. Pertaining then to the hip, dislocation. So dislocation rate, all comers, all surgeons, all prostheses, all approaches, is about 2 or 3%. Again, if you look around the place, in this country and in the UK, where we would have fairly similar standards, the rates of dislocation would be lower than that. And certainly I think most of the regular hip surgeons in this country would have a very, very low rate of hip dislocation. The problem is then when you have your one dislocation every couple of years, that is a very, very unhappy patient, and they take an awful lot of management. Limb length discrepancy is the commonest cause of litigation in North America following a hip replacement. It is not as big a deal here yet, but invariably the lawyers will get wind of it and they'll come after us for that as well. Most patients where there's a small discrepancy of a couple of millimeters, most patients do not notice it. Most patients who do notice it, as long as their pain is gone, really couldn't care less. What I'm talking about is the big discrepancies. Very, very occasionally, we will deliberately create a big discrepancy because you will have to lengthen the leg because it's the only way of keeping it stable. So if they have a long leg, they can get a shoe raised on the other side and their hip stays in joint, as opposed to two beautifully equal legs, one of which keeps dislocating. But it is a massive source of litigation in the States. It is absolutely mandatory that you explain it to the patient beforehand, because again, you wouldn't have a leg to stand on, if you excuse the pun, if the patient came after you afterwards. Again, it's quite sad that all of this is legally driven, but within orthopedics, the commonest source of litigation is spinal surgery, because obviously the complications can be very severe. Hip replacement surgery is second on the list. So patients who have problems with their hips, they don't like it, they're not happy. As far as they're concerned, they're the only one in the country this year and they come after you. The sciatic nerve, the books would suggest that gets injured in about 1% of cases. It's probably lower than that in the real world, but no harm to give people 1%. Intraoperative fracture is on the increase, and the reason it's on the increase is we're using more cementless prostheses. So with a cemented hip or a cemented femur, you have about a 0.7% chance of an intraoperative fracture. With a cementless, it can be up to 2.4%. That's a pretty punchy number. That's a lot of additional work. The last line on this slide is probably the key line. About 95% of patients who get their hip replaced are happy. It is an extraordinarily successful operation. It was in the Lancet as the operation of the century last century. All of these bang for your buck studies, quality of life studies, etc., the two operations that keep coming out through all branches of surgery is cataract surgery and hip replacement surgery. So it is one of the best operations that you can ever offer any patient. The knees, however, are not as good. Patients are not as happy. About 80% of patients who get their knees done are very happy, but that means 20% are not. And it is absolutely essential that anyone coming for a knee replacement knows that 20% of patients are dissatisfied. That dissatisfaction ranges from patients who have complications, because of course they're dissatisfied, that's reasonable, to patients who it's just not quite what they thought it would be. Or I thought I'd be better faster. A lot of what one would refer to as vague dissatisfaction, but it is a definite entity. And I think any knee surgeon who says they don't have these patients in their clinic is quite frankly telling lies, or else I seem to have just got them all, which is incredibly disappointing. In terms of getting over the knee replacement, there's a big row going on in the UK at the moment between their National Joint Register and their knee surgeons, because the National Joint Register in the UK wants patient-related outcomes reported at 6 months. And the knee surgeons in the UK are saying that every single knee improves up to a year, and in fact a lot of knees improve up to 2 years. So again, it's very important when patients are there at 2 or 3 months, when they're thinking, you know, I should be better than this, they still have the potential to get quite a bit better at that stage. But it is a key difference that 80 to 95%, there's been 2 massive studies done, they're both quite aged at this stage, one in North America, one in Europe, and they both came out independently with 81% satisfaction. So again, it's a real figure, it's a validated figure. So we've tried to, by telling them about all the terrible risks and that they won't be satisfied, they've still decided to come ahead. They get pre-assessed. This is a key part of what we do. We're not cancer surgeons. We're not dealing with things that are bleeding or blocked or burst. This is not emergency surgery. This is elective surgery in the coldest sense. So we need to be operating on patients who are absolutely the best they can be on that day. Now, for some patients, the best they can be on that day is not very good. But if it's the best they can be, then that's the decision we need to make. Patients will be seen down in Blackrock by a consultant physician. Each of us tend to work with a specific physician, so we get to know their foibles, and perhaps more importantly, they get to know ours. They'll be seen, they'll be examined, they'll have baseline investigations done. Perhaps what's most important is once they come in, any additional follow-up investigations that need to be done. That'll all be followed up on in parallel while they're getting their joint done. And perhaps most importantly, all of our consultant physicians with whom we work liaise very, very closely with our anaesthetist. And again, most of us would have one anaesthetist that we work with on a regular basis. So our anaesthetist and our physician would have a very good relationship. And again, they work out what we will do and what we won't do. That's a really important part of getting the patient as good as they can be for surgery. And a lot of their concerns and anxieties dissipate at that visit. On the day of surgery then, or indeed the night before, some patients who will be first on the list or second on the list will be they will be admitted the day before. Most patients will be admitted on the day of surgery. This is an initiative that has really come in across the health sector. Up to about 7 or 8 years ago, 1/4 of all surgical beds in Ireland were occupied by preoperative patients. So thankfully we've seen sense and got rid of a lot of that. Patients will either come straight to the DOSA lounge, which is immediately adjacent to theatre, or they'll come onto the ward. And again, it's very useful to explain all that to the theatre, because they walk in the front door of the hospital and about 45 seconds later they're one door away from the theatre. That can really take their breath away if they're not expecting it. Most patients will have a spinal anaesthetic. They do not have a general anaesthetic. There are a lot of perceived advantages for us related to spinal anaesthesia, but a lot of it's based on data from the 1980s, and I think a lot of it is probably moot at this stage. Probably one of the single biggest changes, particularly in relation to the knees, is some of the peripheral blocks that our anaesthetists give. And the skilled anaesthetists at these are really fantastic, and their patients are literally pain-free throughout. There's increasing evidence to suggest that if you can get on top of a patient's pain in the first 24 hours, they get up earlier, they get up faster, they do more quicker, they go home faster, they're more satisfied. So this is a huge component. This is before we've even picked up a knife. This is a huge component of the overall management of the patient. Tranexamic acid is an antifibrinolytic that has come into lower limb arthroplasty probably over the last 8 to 10 years. It's probably been big time in Ireland the last 6 or 7 years. It's knocked our transfusion rates out completely. We did a study in Tal of my patients. I had dropped my transfusion rate to 2%, and they were all really chronically ill medical patients. I think my transfusion rate in Blackrock is actually significantly lower than that. Another point that patients need to be aware of, if they are coming in for bigger cases like revisions, they may require a short stay in the ICU or some form of high dependency nursing afterwards. Not because anything went wrong, not because we didn't do our job properly, but because it is an enormous physiological load on the patient. And again, if there's any suspicion that the patient, it would be most unusual after a primary procedure, but certainly for the revisions, patients often require bed and breakfast in the ICU. Again, if they wake up in the ICU, themselves and their families are most disappointed, and their first thought is, what the hell has gone wrong? So we need to just make sure that they're very clear that that might happen to them on the first night. This is what a hip replacement looks like. So the 3 types of hips we do, I can go through any technical details if you like. This is still our workhorse. This is the cemented total hip replacement. That's a polyethylene, which is a very hard plastic cup, and it's a metal stem, and they're both cemented in. And that still, particularly in our older patients, that still works fantastically well. Again, I quoted the NJR in the UK. Of all the outlying hip surgeons in the UK, not one of them is a full-time cemented hip replacement surgeon. So it works very, very well. This is a hybrid, where again we have the cemented stem and an uncemented cup. And then this is a cementless, where both the femur and the acetabular component are uncemented. For us, they're more fun because you get to knock them in with a big mallet. So we like them, but they are generally, we save them for younger patients. They do have some additional complications associated with them, and they are significantly more expensive, so they probably are not the operation for all patients. This is what a knee replacement looks like. This is metal. This is metal. In the middle is a little polyethylene slab, so the actual joint that articulates is the metal from the femur on the polyethylene. The reason this is different to this is one of the things Diarmuid talked about controversies in the shoulders. One of the controversies in the knee is whether you leave the posterior cruciate ligament in situ, as we do there, or take it out, as we do there. At 10 years, there's absolutely no difference whatsoever between the 2 types of operations, so you just do what you're comfortable with. Similarly, this patient here has had their patella resurfaced, whereas this patient hasn't. At 10 years, there's absolutely no difference in outcome between that either. So in North America, they nearly all resurface the patella. In this part of the world, there's very few resurface the patella with any regularity. Day 1 post-op, again, in terms, what can the patient expect? So those of us who use drains, Again, drain is a matter of preference. There's no hard evidence either way. They get the drain taken straight out. I had a couple of joints yesterday. I went to see them this morning before I came up, so their drains are gone already. The physios see them early. And again, if you go back to Charnley's time, who's probably the father of modern arthroplasty, Charnley's patients all spent their first 6 weeks in bed. And then they couldn't work out how all their patients were dying of pulmonary emboli. So our patients are, I mean, my patients from yesterday have already had their first session of physiotherapy, so it's a completely different mindset. And again, when you're seeing the patient beforehand, you tell them that. Because a lot of patients still think that they'll get their hip or their knee done, and then they'll get a couple of days off. After a couple of days, they've gone home, so they certainly don't get a couple of days off. It's fully weight bearing, and that is the goal of the surgery. If very occasionally, for a technical reason, we might restrict their weight bearing in the early stages, but the vast majority of patients are fully weight bearing, full foot to the ground the next morning. Similarly, with revisions, as much as we can, we try and get them fully weight bearing straight away. They'll start with the frame, they'll move on to the crutches. Some of the better patients will be on crutches this evening. They fly through it. Check their hemoglobin. Again, I've mentioned the tranexamic acid. Transfusion has gone way down. Check x-ray. It's nice to know we have done it properly, not just be relying on our intuition. Perhaps even more importantly, if there is something wrong, it's better to discover while the patient's still in hospital than when they come back with a little letter on expensive notepaper in their hand. Analgesia I've mentioned, anticoagulation I've mentioned. Essentially, you can anticoagulate your patient whatever way you want. We're not subject to things like the NICE guidelines that they have in the UK, which are absolutely rigid, and UK surgeons cannot step outside them. What the vast majority of surgeons do in this country, not through any regulatory mechanism, but because we basically all kind of agreed it made sense, the vast majority in this country give Clexane for 3 days and then 150 milligrams of aspirin for 6 weeks. It's pretty cheap, it's pretty easy, patients can comply with it. And the other thing is the fact that the vast majority of us do it, it offers us a defense later on down the line because it is essentially established peer practice. Days 2 to day 5, most of our patients thankfully don't even see day 5, which is great. They start mobilizing more and more. They go from the frame to the crutches. They start reaching really important milestones. And again, when you talk to patients about this, these are huge victories for them. The first time they go to the loo on their own again is a huge victory. They haven't had to be helped by the nurse or the HCA. First time they can have a shower on their own is a huge victory. They're working away at their exercises, and usually then the last check that the physios do is make sure they're safe on stairs. There's no point having them walking beautiful straight lines. They go home, they go up the stairs, and next thing they come tumbling back down the stairs. That doesn't work very well. They go home on oral analgesia and wound management. I've alluded to infection a couple of times, and I do it deliberately with no apology because it is so important. I mean, certainly with the registrars, I always tell them you can put a hip in backwards, and if the wound heals, it has a chance. But by the same token, if you do the best hip you've ever done and the wound breaks down, the joint is gone. So the wound management is essential. From discharge to day 6, the vast majority of our patients go home. Some will need some rehabilitation, either for their own health reasons or for domestic reasons. Most of us will have our clips or sutures removed at 12 to 14 days. A lot of you facilitators in that regard. Just one mention of clip erythema. Those of us who close wounds with clips, the staples, at about day 9 or day 10, those wounds can start to get a little bit red. And then when they get the clips out, usually about day 12, after another day or two, the redness is gone. A lot of patients get very upset and think that they have got a wound infection. They haven't. It's not something you tend to see with patients who close subcuticular or patients who had it closed with nylon, but with the clips, they can get this clip erythema. We keep them with their TED stockings for 6 weeks, so our summer patients absolutely hate that. Keep them on the aspirin for 6 weeks. Crutches and sticks, everyone has their own attitude towards this, and again, it might be discussed in the panel. Some patients will stay on a stick or a crutch for 3 or 4 months because they're just not confident. That's fine. There's absolutely no point in bullying a patient off their crutches or off their sticks and then they fall and break their femur around their hip. That's pointless. By the same token, you get some guys who walk in for their 6-week visit with their crutches tucked under their arms, so clearly they're doing fine. Follow-up, at the 6-week visit, we check their wound. I've alluded to it on multiple occasions. How is their pain? So what you want is the patient to say that the pain I came to you with is gone. And whatever about the knee, in a hip, it is literally like that. They wake up after their hip replacement. Now, they're sore because someone has stuck a big knife in the side of their leg, but the pain they came to you with is gone. Normally, they will all tell you that they're sleeping much, much better. They're walking better. You want to check their hip abductors. I mentioned that earlier. The hip abductors, the ones out to the side, you want to, certainly if you use the anterolateral approach, which is the one I use, that the hip abductors are a little bit slow coming back, so you want to make sure they're firing back into life, because that's what will give them a normal gait post-op. The knee range of movement is very, very important. We all would do, I don't know, 1 or 2 MUAs of a stiff knee each a year, so it's a very low traffic, but you want to pick the stiff knees out very early on. So if you've got someone at 6 weeks who is struggling movement-wise, I normally give them another 3 or 4 weeks, and if they're not moving at that stage, I bring them in and I manipulate them. Again, it's not a huge percentage of our patients, but what you don't want is to see a stiff knee at a year, because your chances of improving that is very slim. 6 weeks, we stop the TEDs, we stop the aspirin. We let everyone back driving at 6 weeks. There is absolutely no science, no evidence, no literature behind this. It is essentially an international norm. Everyone is off driving for 6 weeks. Someday someone will come up with some evidence that will help us. We let them go back to long-haul flying at 6 weeks. The long-haul flying issue is an issue of comfort. One, they're cooped up in an airplane seat for however many hours, and obviously the risk of clots. Patients going over to London or Manchester or Birmingham or something that first week, 6 weeks, that's not a big deal. I see them at 6 months, I see them at a year. I personally continue to see them in the absence of a joint register. I think everyone around the country has their own pattern in that respect. The final question then that I'm going to cover is, how long is this going to last? And they'll all want to know, particularly the younger patients, because again, if you go back to Charnley's time, the cutoff was 65. So if you weren't 65, you didn't get a hip or a knee, and certainly when we started training, or certainly when Paul started training, the Charnley rules still applied. That was only a couple of years ahead of us, though. The Charnley rules still applied. So if you weren't 65, and you remember in Kappa, guys would come to the clinic, and guys at 58 or 59, and you would basically say, come back in 6 years. That's gone. So my own range, the youngest hip I've done is 17, the oldest I've done is 97, so there's no real age issue anymore. But particularly the younger patients, they want to know how long is it going to last, and will I need to have it revised? So the best evidence we have in respect of how long joints will last is from the various joint registers. This is from the New Zealand register, and you can see here at 18 years, your chances, if you take the middle line, your chances of your hip still going strong at 18 years is about 86%. That's not bad. So if you take patients who are maybe late 60s, early 70s, mid 70s, if you add 18 years onto that, you know, Darwinian self-selection will take care of a lot of your revision procedures. The knees, this is from the UK register. Again, if you just ignore the top 2 lines, I'll come back to them. At 13 years, men should have about a 95%, 94% retention of their prosthesis. Women even better, a fraction better. These top 2 lines, I'm not going to go into any great detail, these are patients under 60. So patients under 60, and particularly men under 60, and even more so men under 55, and we all see increasing numbers of them in our clinics. Their knees do wear out faster, and certainly they need to be made very aware of the fact that, you know, this will do you nicely, but you will need this redone at some stage. So in summary, we are seeing increasing numbers of patients who need lower limb arthroplasty. As I've shown you the first few slides, we're going to see even more. Our patients are younger and younger, a bit like Diarmuid's skydiver. They have more and more functional demands. It's not like the olden days where you could tell them to go away and come back in 5 years. That doesn't wash anymore. Having said that, the main reason for doing a hip or a knee replacement is severe pain not responding to conservative management. That has never changed, and I don't think that ever will change. In terms of investigations, despite the heartache your patients give you, all we really need is plain film x-rays. And again, it's still, even the knee at 80%, but particularly the hip, they remain extraordinarily successful procedures, and the vast majority of our patients really are very, very happy with their outcomes. Thanks very much.
Well done, John.
Do you want a microphone?
No, I can speak loud enough, John. Thank you,
All
John,
right.
for that. I've been asked to chair this session for a bit. We've got, the internet is absolutely buzzing, John. We've got one question so far anyway.
Oh, right, okay.
So from a Dr. Matthews, he wants to know how long would you advise hip precaution durations for it in terms of, I suppose, safety for dislocation risk, etc. So what do you tell your patients about that?
So I suppose the first thing, and actually we're looking at this towel at the moment, is the abduction pillow, the big triangular wedge that you'd have all seen when you did your hospital rotations. That's really old hat now. I mean, we're essentially getting rid of it, but it's part of arthroplasty folklore. I think there's no evidence whatsoever for its use. So if someone turned around to me in the morning and said, we're not using abduction pillows, I'd live with that. There's no real precautions for the knees. For the hips, the precautions are what they get taught initially by the physiotherapist. And it's all about just not doing stupid things, not hyperflexing, not putting themselves in positions of danger. Really, they're lifelong precautions. And I'm sure, you've seen, it's amazing. You get patients back at kind of 7 or 8 years with an occasional dislocation because they just lost attention for a while and they sat in some really deep armchair and suddenly it popped out the back. Now, obviously, their tissues wouldn't have been as good as day one. So the precautions are instilled at the beginning, but really, the stay safe and stay sensible, that pertains forever. What do you tell them? Just don't do something stupid.
Don't do something stupid, but I don't worry about them after 3 months. I think they take their chances after that, and they, once they reasonable. But I have people who ski, like they surf, and they do everything in terms of demands, and their hips seem to be inherently as stable. I think the big advantage or change that happened with hip replacements is that we moved from small head hip replacements to larger head hip replacements, and that makes them inherently more stable. And therefore, I suppose that the legacy of the metal hip replacements, which we're resurfacing, is that now we've got rid of them because the metal reactions didn't suit the patients. But the legacy is that we now use more larger head hip replacements, which are inherently more stable. So the abduction pillow after a day, I don't use it anymore. And really, after 6 to 8 weeks, I'm really not worried about dislocation. And touch wood, never had a primary hip dislocate. Visions, unfortunately, do dislocate, but that's different.
They're a different beast,
There's a few questions there from the floor.
Yeah, I'd like to. We're hearing a lot about anterior hip replacement being getting better, quicker results. Difficult and all as it is, there are some people, they train in this a lot and they say we get quicker results and the person doesn't suffer so much. That's one thing I want to ask. And when you answer that, I'd like.
Okay, so the second question depends on whether you like the first answer. I expected we would be asked about that. In the States now, about 40% of hips are done through the direct anterior approach. There's no question the patients do get out of hospital faster. But having said that, our length of stay now is so short that the average improvement of length of stay is only a day or a day and a half. It's not that significant. Part of it in the States, it's massively commercially driven because they're now trying to get towards day case hip replacement surgery, which is not quite what it suggests, because most of them, after their day in the hospital, go to a hotel or a motel down the end of the street that is owned by the hospital, where there might be one nurse looking after a floor as opposed to it. It is less uncomfortable. They do get up a little bit faster. They do get out of hospital a little bit faster. The results at 6 months, a year, and 5 years are absolutely exactly the same. And from a technical perspective, it is an approach that you need to have a surgeon who's doing a very high volume of them. It is not one for the occasional surgeon because it has quite a steep learning curve. And there's a lot of mistakes. And we have a couple of people in Ireland who've done lots of them, and they're very honest about it. They'll tell you about all the mistakes they made in the early stages. But it's a massively commercially driven entity in the United States.
Second question is, having done knee replacements on people who are hill walkers and what would you think of those people going back to doing what they did?
I think it's great, because I think that's why you do it for them.
Right. Okay.
I think with the knees in particular, anything that's high impact, they can sometimes struggle with. And the other issue with knees is some of them will struggle to kneel on their knees. But hill walking it's low energy, it's low velocity, and if they can get back hill walking, I think that's basically the reason they came to get their knee done. So I'd be 100% in favour of that.
Thanks very much for that very good talk. What about squeaking hips?
Squeaking pertains almost exclusively to ceramics, to ceramic on ceramic. There's a couple of technical considerations. Again, there's been some evidence in the States that up to 7% of ceramic hips squeak. We don't have that in this country. I think perhaps the mistake in America.
You've got one, I know.
Oh no, we have a few. We have a few. I think in America maybe they keep asking their patients, which is the first mistake, rather than waiting for the patient to volunteer. The newer ceramics squeak less, so the incidence is a lot less. There are some technical considerations that we need to be careful of when putting them in relation to angles and so on. If a squeak is a major problem for a patient, it can be revised. But oftentimes, I stopped doing ceramic on ceramic 2 years ago, but I have about 8 years worth of ceramic and ceramics. I have about maybe 5 or 6 squeakers, and each of them I have offered them a revision, and each time I've offered them a revision, they've told me that the squeak is not that bad.
Yeah, just a squeak. I used to use ceramics, and the occasion you do squeak, it's a stripe wear on the ceramic, and they usually get inflection, so as they squat down, they get it as they come up from a sitting position. Some people get used to it, and it does tend to change a little bit, but it's a bit disconcerting to patients, and I've seen there was one air hostess who had a very bad squeak. Well, I didn't do her, but we changed her liner to a plastic liner, because she was walking down and you could actually hear her squeak, and it wasn't very nice on the plane when what was going wrong with the trolley. So there's some practical difficulties, but it can be a very loud audible squeak. Because of that, though, most surgeons have gone from ceramic and ceramic bearing to a ceramic and plastic, and they don't squeak. So it's you'll see it in patients who were done the last 7 or 8 years ago, but it's largely historical now at this stage because of that. And because unfortunately it's a bearing surface, so you have to change the bearing to get rid of it. And unfortunately put the patient through another operation, so we just decided to get rid of the potential for squeaks because of that.
One of my squeakers complained that she squeaked during sex, so I struggled to offer any major advice on that one. I offered her a revision and I ran.
The patient I have, her problem is that when she's playing golf, everyone keeps telling her that her caddy car needs oil.
She should just go with that.
Another question, John, that came through was about a knee replacement. Do you think patients who are very active should alter their activity levels to make their knee last longer, or do you think that there's any practical difference? Will it make a big difference between someone who wears out at 17 years rather than 17.5 years, but they've changed their lifestyle? Would you advise them to change their lifestyle to make their knee last longer?
No, because I think the activities that, it alludes to the question about hill walking. I think the high velocity activities that you would be concerned about the longevity of your prosthesis. Most patients, by the time they get to knee replacement surgery, they've given them up, and certainly most of them can't ever get back to that anyway. So I think in the knee replacement, they get back playing a bit of golf, they do a bit of hill walking. I don't think the vast majority of our knee replacement patients ever get back to an area that you'd be worried about. I also don't think there's anything published or written that would suggest a fixed lifestyle modification will get you an extra 6 months or an extra 9 months, because we don't fully understand why some prostheses wear out and some prostheses don't. So no, I don't think so.
You showed a slide at the end there, we're talking about the revision wave that you think is coming. It's been talked about for the last 30 years. I remember we started off, we're going to have these huge revision centres in Ireland because we started off with hip replacements. But I must say, you showed a slide there showing, I'm not convinced that the revision wave is going to be as big as we think it is, because I think the surgeons that are putting in hips and knees are of much better quality, and the implants are lasting longer. So you're getting figures there showing 85% last 19 years. But I've seen some of John's dad's great work coming back to see me, and I'm doing their other side, and they have a bog standard Charney hip in, which was only cost about 900 quid at the time, and it's in 25 years. So there's an awful lot of people who still last a lot longer than the stats are showing. So we've talked about this revision wave. It will come to a certain degree, but I don't think it's going to be as high as the stats you show there.
Yeah, I suppose, US data you interpret with a degree of caution, because 80% of joints in the States are done by surgeons doing less than 20 joints. So I agree. I think in this country, most people who are doing hips and knees are doing reasonable volume. So yes, I would agree with that. The prostheses certainly have improved. My time in orthopedics, the knees I started on compared to the knees we put in now are unrecognizable. But having said that, certainly my revisions would be going up most years. I don't think we may not get the wave as predicted in North America, but there's still plenty of business out there. Do you want some?
No. One of the advantages of getting older, you stop doing revisions, John. They're for the young fellas like yourself. Any questions else on the floor? Brendan, yeah?
Yeah, for somebody who has a focal defect of the humerus and the joint space, otherwise very well preserved, is there any procedure short of a total hip replacement which should be considered?
That's very difficult. There's hip arthroscopy. It's not a procedure I do or offer. We have a couple of very good hip arthroscopists in the country. They have very rigid criteria for hip arthroscopy, and for, perhaps more importantly, for not doing hip arthroscopy. And I think if you want an example, someone like Andy Murray would be your example there. It's pretty obvious he was way outside the criteria for hip arthroscopy, but he went for it and it didn't work. So hip arthroscopy is certainly an option. Obviously, if the patient is not particularly symptomatic, if it's somewhat of an incidental finding, you just truck on. There are surgical dislocations then, which can be used more so for femoral acetabular impingement. Again, it was quite the rage maybe 10 years ago. I think it is less of a rage now, because whilst you can address the presenting complaint, you then go and create a litany of additional problems. So I think you would probably treat that patient, if they're not suitable for hip arthroscopy, their options are somewhat limited.
Yeah, in the knee there is sort of some role to play for these,
for the knee,
for chondral buttons, and sort of partial replacement would go. McMinn, who developed the surface hip replacement, had these sort of partial surface hip replacements. They were sort of quadrilateral, sort of an outer third of the hip being replaced, where you put a little cap on sort of it, but that is really sort of no long-term science behind it. No. But you can see Andy Murray went to decide on this, the Birmingham hip. There is no doubt that the Birmingham hip probably would give him the greatest chance probably getting back to professional tennis if he does get back. But he took a chance with his metal risks and irons and all that. That's still unknown. But you know, he'll probably get it whipped out in 10 years' time and have a more standard hip replacement, and he'll have the money to do it, so it won't be a big issue for him.
Correct.
Hi, thank you. It's a really interesting talk. I just want to ask again about a younger person who had a knee replacement. In 10 years' time, what are the symptoms that it is starting to decay, and what physically goes wrong? I mean, is it that the prosthesis gets loose, or is it the polyethylene plate gets degraded?
Polyethylene wears. That's exactly it.
So when you're replacing or revising, are you just replacing the polyethylene, or are you replacing the... So it's only the polyethylene?
In very, very limited cases, you can just do a polyethylene exchange. Once polyethylene starts to degrade or to wear, it sets in place this biological cascade of lots of mediators whose names I've forgotten, it don't matter. But anyway, the final common pathway is exactly the same as bony metastasase. You get bone resorption. And as a result, your prosthesis gets loose. So, you know, Paul mentioned the Charnley hip. That's really where we saw most of the aseptic loosening, which would still be the commonest reason for revising a hip or a knee in this country. It starts to get a little bit loose, so they start to get some pain back that they hadn't had for a few years. It goes back to pretty much the presenting complaints. They can't walk quite as far as they did. The other real giveaway is they start going back on a walking stick. But so that would be a suggestion that the hip is loosening. So when they come in, or I beg your pardon, the knee, when they come in then and it looks loose and their history is that of loosening, the x-rays back it up. Once it's not infected, then you would revise it as per an aseptic loosening.
So you replace the metal and the polyethylene?
Invariably, you take everything out, yeah.
It depends really on the stage of the hip or the knee. If it's an early failure in a knee replacement and it's not infective, usually there's probably a malalignment issue that the surgeon, so if someone failed within the first 5 to 7 years, knee shouldn't fail at that age group. It meant that probably the knee is not optimal in terms of alignment, so by just changing the plastic liner, you're not really addressing, you probably have the same problem 6 years later, so it's probably got an alignment issue, so you should probably revise the whole thing and start from scratch. If it fails late and the patient is old, invariably it's a combination of the plastic failing, and that creates then instability. That usually means the implant starts to loosen as well, and you often see then resorption of the bone, and you won't get away with just a polyethylene exchange with those patients. The big change, I suppose, the last 10 years has been the polyethylene that we put in the knees is cross-linked, and that's a stronger, more robust plastic, and therefore tends to wear out less. So therefore we don't see too many polyethylene failures unless it's a malalignment or instability issue. So there's usually the problem with the knee to begin with. So an early failure in the first 5 years, even though the surgeon might blame the patient, you usually should blame the surgeon.
Thank you.
Any other questions there?
Yes, I've got a sort of a two-part question, if I might. Thank you for your talk. I'm wondering if you're noticing that there seems to be more younger patients coming with a single joint with a relatively acute onset of pain. And I'm wondering if you see a role for trying to temporize with injections to enable physio to see if it'll settle down, or how you decide on timing, especially if x-ray changes are not marked. And the second part is, what do you see as the role for future regenerative approaches like mesenchymal cell injection and things like that?
So take it in reverse, if I may. I mean, the stem cell technology is the cutting edge of research. I think there will probably be a role for it in the future. The stem cells are, I suppose you could maybe describe them as the wonder cure. We just haven't worked out what they cure yet. But there is definitely, you know, from first principles of science, there is or there will be a role for them in the future. I think it will be long, long after all of us in this room have finished practice though, so I'm not acutely concerned about stem cells putting us out of business. The younger patients, yes, we do see increasing numbers of younger patients, no question about it. Yes, we do see increasing numbers of younger patients with single joints. Injecting the hip joint is something I don't offer very often. I don't know, the others might comment on this. It's invasive, it's difficult, you need image control. Sometimes they need sedation, sometimes you do them under general anesthetic. If they're that bad, when I will do it is for a diagnostic test. If I'm not absolutely sure if it's their back or their hip or their knee, I will do it. It's injecting a hip, it's not really, I think, considered a part of regular management. Timing wise, in this day and age, I mean, 20 years ago, the surgeon told you it's time for your hip. Nowadays, the patient tells you, because usually when you talk to them and go through the whole thing, normally they just throw their hands up and say, oh, right, just get on and do it, will you? Do you inject them?
Yeah, I do, yeah. In terms of the first question, beware the painful sort of young person with a knee, I suppose, has got a minor x-ray but very disabled. I suppose you have to make sure the diagnosis, inflammatory arthritis, gout, typically, and then you get this condition called osteonecrosis where you get a SONC, where you get this spontaneous infarct in the femoral condyle. And you don't see, they have a normal x-ray, but they come in looking like an old fellow walking through the door, and they often have a spontaneous osteocrosis. And they recover generally, so you don't make, even though they might be disabled like an arthritic patient, they're still young and they've still got potential recovery. So you'd be conservative of those patients. But injection therapy, I suppose I use it, you know, there's no huge science that the steroid works well for the old ears to keep them going along, and they don't have, they don't want to make the decision for surgery. The suppository injections have some role to play. There's a few studies coming out in the last 6 months that are suggesting they're actually not worthwhile. But I find anecdotally they seem to help some patients. The PRP, we have a study that's up in the Beacon that Morris Nelligan has done a few of them. He says about 50-50 at best in terms of for arthritis for the knee. And then the stem cell is totally, I think, arbitrary. If you want to waste $5,000 on getting something done over in Switzerland, you can, but invariably the patient, when they get the knowledge that they need a stem cell, usually the ship has already sailed, they've got end-stage arthritis and it's not going to regrow. You want to get these patients probably 10 years earlier in this process to try and prevent them developing the radiological changes that you get. So I think stem cell is something that is really something for the future, and it won't be myself or John, and even young John won't even get to use it, I don't think, in his lifetime.
Just before you do the hip replacements, do you outrule osteoporosis of the neck and total hip?
Not really, no, it doesn't. It's irrelevant, really. In terms of our point of perspective, it is. We use cemented, in an old lady, it doesn't matter whether osteoporotic or not, you're still going to put a cemented hip replacement into them whether they have osteoporosis or not. In a younger person, if we were doing it, and when we were doing surface hip replacements, yes, we did osteoporotic screening. But from a technical perspective, in terms of integration of the bone with a cemented implant, it is not, of our point of view, relevance whether they've got osteoporosis or not. It is relevant to the patient from their other protective elements, absolutely, I'm not saying that, but it's not part of our screening process, that we need to know about it from a technical side in terms of doing the surgery, in the way we do it. It doesn't show that it's relevant. But if I had an osteoporotic patient who comes in with a very low density score, I wouldn't put a cementless hip replacement in them. But if I saw that on the x-ray, I would make that decision probably on the basis of the x-ray. And if I wanted to confirm it, I might send it for bone density testing. But I don't need it before I do the hip replacement generally.
I'd agree with that, yeah.
Sorry, this is very basic. With all of the talk, I'm going to come away from this not knowing if I was to go for a hip, which hip do you need? And if I was to go for a knee, which knee do you need? Did you say metal on metal with polyethylene is the knee?
So the old adage, choose your surgeon, not your implant. I mean, patients won't decide which implant they get. As a general rule, for hips, we will use cementless implants on younger patients. Hybrids then on, certainly for me, I would use the hybrid patients between 60 to 75 because that's a very variable group biologically, and anyone over 70, 75 years of age gets a cemented hip replacement. All patients get a cemented knee replacement. Things like the patella and the posterior cruciate, that's just a technical nuance. I mean, I do it my way, Paul does it his way, the lads do it their way. So I don't think patients would have come with a shopping list. Metal on metal resurfacing is gone. in this country. I think you would be, there's one surgeon who occasionally will make some mutterings, but you would be legally indefensible if you tried to resurface someone in this country nowadays.
Okay.
The minute the person comes in with a big list of internet-driven data in front of them and start talking about, are you going to use ceramic bearing posterior or whatever stabilizer, you suddenly raise all alarm bells straight away. This is either a high expectation patient that needs to be flattened fairly quickly in terms of, if you survive the operation, you're doing well. If you don't get infection, I'll be happy. And if you can go out playing golf, it's a great result. So you completely dampen their expectations. They're a dangerous type of patient in terms of, we don't mind educated patients coming through, but it's a bit of a red flag when you see that type of patient coming in. At the end of the day, what John says is right. It's who puts it in is much more important than what you put in, to be honest with you. And that's the sort of science behind joint
Okay, I'll
replacement.
shut up.
No, you're fine. No, I don't mind that, but I think it brings an open. You know, it's sort of one of the great skills of a surgeon is learning who not to operate on.
Yeah.
And sometimes the hardest thing you have to tell a patient is you're not bad enough that you need something done at this stage. We live in a world where everyone wants all their problems solved. And sometimes it takes a little bit of balls to stand up and say, you know what, your hip is bad, but I'm not going to do it. And I know patients have gone off to someone else and got it done. But there's a reason why I probably felt that, not because their disease process wasn't sort of present, but maybe psychologically the patient was sort of not ready for it, or they're too demanding, or weren't respecting the procedure. I think, you know, if you don't respect surgery from a patient perspective and respect the risk you take from it, your expectations and sometimes is totally mismatched, and it's a huge factor we have to factor in with patients. But when the patient comes in with that sort of patient, you know, it's a bit of a heartbreaker. We spend half an hour discussing technological aspects of their process, which really is irrelevant to them. They're coming to you to ask you what's the best thing to do and what you should do, and they have to trust you from that point of view. So it brings up an important part of the discussion in that sense, but it certainly means, from my point of view, it's a totally different conversation I have with those sort of patients rather than the laid back, you're going to be great, everything's going to be fine type of conversation with a more level sort of headed patient that lets you decide the implant choice. Obviously the patient is important in terms of decision and timing, but it opens up a little bit of a angst. Would you say, John?
I mean, many of you will know Ozzy Fogarty, who worked in Crumlin, as he says that the pressure on us nowadays is that, you know, patients, not only do they expect to survive, some of them actually look to be cured. So there is definitely, as Paul says, you need to manage expectations. Internet positivity is one of the greatest diseases we see on a regular basis. There's no doubt, as I'm sure yourselves do.
The other thing just to highlight, I suppose, is the big change I've seen over the last, say, 10 years would be the recovery has been dramatically different in terms of joint replacement. That's a combination of, I suppose, for the first time, the surgeons took over with their anaesthetic, and we were sort of let, in the past, the anaesthetist used to decide the sort of pain management, essentially. And it was really not with the greatest impact to the patient's recovery. And a lot of patients got these PCAs and epidurals and all that. And it basically just tied a patient to bed for 24 hours, 48 hours, and then they were vomiting with all the amount of morphine they got. So we've really made a big advances in terms of anaesthetic pain management with good cooperation of our colleagues and blocks, as John was showing earlier on. It's all about getting the patient up and going. It suits the hospital, but also suits the patient a lot more quicker. And then we've introduced a lot of early aggressive physio in Blackrock. They have same-day physiotherapy, so if they have surgery in the morning, they're out of bed in the evening time, and then they have physio to get them out and about. And we've reduced the hospital stay to around 4 or 5 days. This obsession with trying to get patients out the door is fine if you're in America or Germany, where they go home on day one, and then they go off to their local sort of rehabilitation centre where they attend every day for the next 6 weeks, having physio and all that. But we've got patients that go home and they don't see no one for 6 weeks. So you have to be careful and conscious that we live in a different environment, that they do need about 3 or 4 days to get over any surgical procedure in that sense.
Having said that, I mean, 10 years ago when I came home, the average length of stay for a hip replacement patient in this country was 11 days. So in 10 years, we've dropped it from 11 to about 4.5 or 5 days. So we've made, Paul's point's absolutely correct. I mean, I mentioned about the day case surgery that the Americans go on about, but they get discharged from the hospital to the hotel down the end of the street, which the hospital owns. So it's not exactly going home. So, and Paul's right. I mean, some of our patients do go home and they're left somewhat stranded, yeah.
Any other burning topics we want to discuss? What's that, Fergus? Just hold it. Just wait for Mike.
I have a patient who's insisting on having both knees done at the same time. Could I have your comments on that, please?
So I I actually am very open-minded to that. I'm not looking for your patient. When I did a year in New Zealand, and we did a lot of bilateral joints down there, and it was very much a part of standard arthroplasty practice. It is not something in this country that has ever really taken on. Before I started in Tal, I was down the southeast, and I tried a couple of bilateral hips and a couple of bilateral knees, and let's just say I wasn't feeling the love in the hospital. So I think in the appropriate patient, I think it is an absolutely fantastic operation. In my opinion, the appropriate patient is a youngish man who's not heavy and has no comorbidities. I think a bilateral knee in that patient or a bilateral hip in that patient is a fantastic operation, but getting the collective buy-in for it is not easy. You done many bilaterals?
I did them in training. James Cashman down in Cork did a lot of them, but they were all carefully selected. In some ways, you can see the rationale behind it. If you have a crook both knees, you can't get going. If you have one operation and then you have to wait 6 weeks to have the other one, the patient often mentally turns off. They're waiting to get the second one done before they really push the effort in. So therefore, the increased incidence of infection or stiffness, DVT, etc., is higher. So there is a role for it in carefully selected patients. Fintan might discuss, maybe Fintan has done a few bilateral hip replacements at the same time, so maybe you might just answer that, Fintan, from a hip perspective.
Yeah, from a hip perspective, it's actually riskier than the knees, because as John said, you let the knees go off and do whatever they want. The hips, you're a bit worried about stability or instability in the first 6 to 12 weeks. But there is definitely a role for it, and there's an actual indication for it in patients who've fixed deformities of their hips. So if someone comes in with bilateral fixed hips, and you do one and then do the other 6 or 12 weeks later, the first one you did will probably be flexed by the time you do the second one. So there is an indication for it, but those patients unfortunately are usually not medically fit to have both of them done. Most of the patients I would do are young, active men who have similar symptoms on both sides and can't take 3 months off work and just want it all done in one go. And the risks are a bit higher, and their length of stay is a little bit longer. But they're some of my happiest patients, because when they come back at 6 weeks, they say, that's it, I'll see you in 20 years.
The only thing I'd say about the hips, though, if I'm doing hips, I do cementless hips, because the total operative time for bilateral cemented hips, you're getting out towards 2.25, 2.5 hours, whereas you could probably get bilateral cemented hips, cementless hips done in about an hour and a half, so the physiological assault is much less. But the length of stay is longer, but it is significantly shorter than the cumulative length of stay. So, I absolutely agree with everything Fintan says there, yeah.
Obviously, the key is patient selection, and there will be the occasional person that you might decide to do it on. But it brings up another topic, actually, that's just before I finish up, would be psychological profiling in patients. It's common now in the States that patients, say, particularly having knee replacements, go to see a psychologist, and they're getting psychological profiling. We also know a few patients that come through the door and you sort of say, geez, I think you should be sending him to a psychologist. But the problem is if you send one particular patient to it, you have then a difficult situation. So it's been sort of generally introduced that pain psychologists and psychological profiling patients is something to consider for joint replacement, and it will probably come into pre-assessment at some stage, I would feel, because we're getting more and more demanding patients, and particularly the sort of red flag patient comes in with a very disabled knee or disabled symptoms in the knee, and then you look at the x-ray report and it's minor arthritic changes. So they have an awful lot of soft tissue components to their pain, and sometimes those patients who often have a psychological component to their pain as well. And they're the patients that you probably should be certainly profiling from a psychological point of view before you consider a surgical solution for them. What do you think about that, John?
100%. We could be flippant and go through the list of people who wear sunglasses indoors and own cats and so on, but no, being serious, that is absolutely correct. Some patients come in and before they sit down, you've thought, I'm not operating on this person. So absolutely, I would 100% agree with you.
You need an excuse sometimes, and that's where the psychologist can help a little bit.
Yeah, I send them on to you. I say you have more experience.
Well,
Am I right? He can't ask questions. He's not allowed. Thanks.
So I'd echo that completely. There's actually quite a lot of work around in the shoulder world around psychometric testing preoperatively and streaming patients into pain management programs rather than having them waste their time in surgical clinics. So, and that's actually something we're hoping to look at soon ourselves. But the psychometric testing, there's several psychometric tests that are being used currently that will indicate that the patient's outcome surgically is going to be poorer if they are of a particular bracket. No
Where
question.
it's going to become an issue is if the funding models change, and I alluded to this in the States and in the UK, where patient-related outcomes are part of the follow-up. Once patient-related outcomes start getting married to funding streams, we will then have to get far more aggressive about our patient selection. Because if you have a patient who in good faith you've operated on their hip or their knee and they remain residually unhappy, that will affect the financial aspect of the whole component, be it in the public health sector, the private health sector. I think it's reasonable. They've started in the UK, so I mean, we have this habit in this country of anything they do really, really badly in the UK of adopting it for our health service, so I presume it is inevitable.
Jerry, just one other thing you forgot to ask in your talk, just the medical legal rotator cuff tear. The patient who gets off the bike, hits the ground, and he's 50, he probably has it there already, and now he's got a painful shoulder, and he's got a reason for it to be painful because he's got a financial inducement to stay painful. So how would you handle the medical legal rotator cuff injury?
That's very interesting because, like all things, how healthcare is funded impacts on what research is done around it and how services are provided. So actually in New Zealand, where a lot of the healthcare is funded through a system called the ACC, or Accidents Compensation Corporation, they have to determine whether something is in fact traumatic or degenerate. And as a result, there's actually been quite a lot of work done in New Zealand with regard to the differences between radiological appearance of rotator cuff disease and its relationship with acute trauma. And so effectively, if you're looking at an MRI scan that shows that you have a tear on or if you identify at arthroscopy a tear that is clearly degenerate, there's no lateral stump, so that there's no residual piece of tendon left on the bony side at the lateral aspect, and there's a lot of fraying and degenerative changes. It is possible to say that that is a degenerative tear rather than a traumatic one. One of the issues, though, relates to the timing of onset of the pain as well, needless to say. So there will still be a temporal relationship between the onset of the patient's shoulder pain, but the tear in and of itself couldn't be considered to be acutely traumatic if it doesn't have those radiological findings.
And what do you think about the MRI meniscal tear in the person who's a medical litigant?
I think it's quite prevalent.
Because unfortunately, we get a lot of MRI scans reports, and a proposed dilemma for GPs: who to send on? Do you send them on to me or to John or wherever else? They come back, they have a painful knee, and they have an arthritic process in the knee joint, and then they've got a significant medial meniscal tear. And the radiologist doesn't tell you whether it's a big, large, it's degenerative, it's part of age, and then you're left with a patient who's sore, and then you end up coming to see myself or some of the lads, and we sort of say, look, that's not the meniscal tear causing the pain, it's your arthritic process all along. And we spent 20 minutes trying to convince them that the radiologist is wrong. So we were sort of a little bit let down by our radiology colleagues. I think the first word of any MRI scan should be the age of the patient, and the second thing should be just commenting on the most obvious problem, which is usually the arthritic process. And then he might mention the last paragraph that there is a meniscal issue here that may or may not be contributing to their components. But just saying there's a medial meniscal tear, I think it leaves the GP in a vulnerable situation. Well, why did you refer me? I had a torn cartilage, etc. And then you have a lot of the patients that are coming through that just have an arthritic knee that we don't need to do a scope on, but they're hard to select, I suppose. You have to go back to their symptoms. If they don't have symptoms of meniscal tear in terms of catching, locking, pivot pain, rotatory pain, or meniscal pain, it's probably just the underlying arthritic process, and therefore you should treat them as an arthritic patient rather than a patient that needs a surgical solution. But they're hard to weed out because the radiologists don't help us the way they report the scans, unfortunately.
No, the problem is once the lawyers get involved, it's a different situation. We saw this a lot with the metal-on-metal hips, particularly with the Dupuy hip, which they recalled in 2010. So between about 2010 and 2014, we did a rash of ASR revisions, and patients came in and their life were, and now, to be very clear, a lot of patients' lives were destroyed by the ASR, but a lot of patients came in and they were crippled and they were this, that and the other, and we revised them because they needed to be revised, and then they got a settlement, and then after the revision they were cured, so therefore clearly the ASR had caused all their problems. Then they got a settlement, and there were some fairly substantial settlements, and that process is still ongoing. And then at about a year, like pretty much every metal-on-metal revision that we've all done, I think we've all done metal-on-metal revisions, they started getting very unhappy again. So there's no doubt about it. Once the lawyers are involved, the whole pathway alters significantly.
Well, the game is to avoid the lawyers as much as we can, unfortunately, but
That's
it's inevitability. Yeah. So any other burning questions before we move on to this pain section? So thank you, John, for a great talk.
Thanks,
Dermot, it's another great talk. Thanks a lot.
Thanks very much, John. That was great. I'd like to introduce now Dr. Ty Glinch. He's a consultant in pain medicine with us in Blackrock Clinic. His special interests include interventional and multidisciplinary treatment of chronic pain. So thank you, Ty.
Thanks, Chris, and it's great to be here. Everybody just feel free to get up and have a cup of coffee or something to eat, because we've been here for a couple hours at this stage, so it's not going to bother me if you want to get up and stretch your legs. It's really important to move around and get the spine going. So I think the last two talks were really interesting because there were some topics touched on that make a big difference to patients with back pain in particular. The psychological aspect is a really big aspect, and of course as GPs that can often be the biggest aspect. And I suppose when you do psychological profiling in people who are likely to get to be dissatisfied afterwards or have low satisfaction scores, you often find that they have high scores of neuroticism, catastrophization. You can identify those people before they have surgery, but you know, what do you do then? You probably go through a psychological program where you try to reduce their catastrophization, but the reality is that if people are in pain, they're more likely to have anxiety and depression. And although somebody might have that personality type, they may still need the hip or knee replacement or still have the back pain. So it is difficult because it isn't always in somebody's head. Okay, there are the somatizers and they're very rare, but it is a combination of the psychological aspects and the physical aspects. And actually, next week we're starting, coordinated by the physiotherapy department, the first pain management program, or you could call it, you know, a health management program, because there are going to be patients with not just chronic pain in Blackrock Clinic. So it's a 7-week program. I'll talk about it later on in the talk. So maybe that'd be, you know, something that you could refer patients into, you know, directly, you know, if you're concerned about a patient, rather than sending them through the normal channels. And I'll mention that, so that'd definitely be of interest. So I wanted to talk about what works for pain. Could I get the slides on the screen in front as well, or I'll just turn around? Sorry? Can I get the slides to come up on the screen in front as well? So a lot of patients say, oh, the pain was chronic. And it was like when patients were calling up Joe Duffy about the removal of Bursitis lignocaine patches, because they were being prescribed to so many patients, and I prescribed them to patients, and the patients they worked for tended to be slim people with back pain. So usually the facet joints, for example, are like 10 centimeters deep in the spine. Local anesthetic patches aren't going to make a difference. But if somebody is slim, some people did get a difference, and then the HSC said, we're not going to pay for them because we're paying 700 million a year on them, and it doesn't have the evidence. Well, I suppose the evidence hasn't been collected. They were licensed for people with post-herpetic neuralgia, but they did work for people, and you know, that's where people say, oh, chronic pain, what is it? It's basically pain lasting more than 3 months. And of course, patients come in and say, my pain is 10 out of 10 all the time, and you're kind of thinking in your head, it can't be 10 out of 10 all the time, because you get flare-ups, and then it settles down and flares up again. But it's, I suppose, what patients' perception is really important. And again, the pain versus function is really important too. So chronic pain is very common. There was a big PRIME study done in Ireland which showed that over 60% of people over 65 have chronic pain on a daily basis. And that's either major joints, so hip and knee, or spinal pain in general. So thankfully, there are really good operations for hip and knee pain. So if somebody is suffering with severe pain due to osteoarthritis, you can replace the hip or knee, but you can't replace the back. There are very effective surgeries for particularly for sciatica. So if a nerve root is compressed, decompressing it should give relief 95% of the time. But for back pain, if there's normal structural alignment, no compression, no stenosis, I think surgeons are doing less spinal fusions than they used to do in the past. And Mr. Sitar is here to talk about the surgical side of things as well. So, you know, disc degeneration is a normal part of aging. Hair goes grey, we get wrinkles, we get degeneration in our spine. And common to what Dermot was saying in terms of shoulders, if you do an MRI scan on everybody over 50, everybody's going to have degeneration to some degree. So when is it actually important? But what I'd say is that when you say to somebody, oh, they're only just wrinkles, who wants wrinkles? You know, people still don't want to have degenerated discs. But the reality is that you do get disc degeneration over time, and you don't necessarily have pain from that, but I suppose people have an MRI scan, you know, because they've had back pain. So I just mentioned there that it's common to have wear and tear changes without any pain. So medication management is a big part as well of being a GP, because you see so many people in comparison to maybe the more severe patients that I would see, or my surgical colleagues. And I worked as a locum GP, you know, earlier in my career when I was training as an anaesthetist and then pain specialist, and actually looked at being a GP because it's a really enjoyable job. Mainly in the west of Ireland is where I was, and I know that it's difficult because you see so many patients coming in saying, I got up this morning, I've got really bad back pain, or I twisted yesterday, I've got really bad back pain. I've been taking salpidine and Nurofen, I need something. So the difficulty now is that evidence has shown that if you have a high risk of cardiovascular disease, that you're increasing your risk of a cardiovascular event by 1/3 with anti-inflammatories. So although the golf courses around the country are littered with empty Difene packages that patients may bring with them from Spain, you know, as GPs and clinicians now, we can't put people on strong non-steroidal anti-inflammatories on a chronic basis in the way that we used to in the past. And similarly, strong opioids, it's in every magazine that you pick up that there's an opioid crisis in the United States. 60,000 people are dying a year of opioid overdoses. That's not all prescribed opioids, it can be illicit opioids, but it's a difficult position because a lot of our patients are already on the medication. Even if we didn't prescribe it anymore, a lot of patients are on 60 milligrams of OxyContin, BD, and Oxynorm, PRN. It's massive doses, and fentanyl patches are very, very potent. And the difficulty there is, you know, when you try to say, I want to reduce your medication, patients will say, well, what am I going to do? This is the only thing that's keeping me going. But I think trying to limit the amount of prescriptions of the strong opioids in particular is a really good place to start. So sometimes I say that back pain, patients think of back pain, oh, it's my back. But as doctors, we kind of look at it in a different way, and we try to say what structure in the back is what's causing pain. So sometimes it's useful to think about it like a heart. So a heart is an organ, but it's got different components to it. So basically you have narrowing is like wear and tear, conduction system is like neuropathic pain, the different sides of the circulation are like the front and the back of the spine, so the anterior column and posterior column, and then you can have inflammatory conditions, spondyloarthropathy, you know, young patients who have the single major joint inflammatory pain with less osteoarthritis on an x-ray, or somebody who's got low back pain, always ask about a family history, always ask if they have any skin rashes, psoriasis, and increasingly I do check for HLA-B27 and autoantibodies because there will be patients who have got, you know, positives there. And the great thing about the monoclonal antibodies that the rheumatologists are prescribing is that they do stop the disease in its tracks. Now, they do potentially have complications that we may see more of in the future. For example, they can increase the risk of, you know, squamous skin cell carcinoma. So we may see these things down the line in terms of the strong immunosuppressants, but they do really stop the degeneration of the rheumatoid patients. So again, I was saying that, you know, when I think about a patient, I think about what can I do to make them better? Well, what can I do to help them? And I think, is it anterior spinal pain or is it posterior spinal pain? So that's really, I suppose, it's for me as somebody who's going to be putting needles in to do diagnostic blocks and to treat patients. It's a really important thing. Maybe as a GP, your prescriptions are kind of going to be the anti-inflammatories, the moderately strong opioids, paracetamol, sometimes muscle relaxants in short courses. But for me, I want to know, is this disc pain or is it facet joint pain? Because disc pain is difficult to treat, facet joint pain is a lot easier to treat, and it's the low-hanging fruit really of back pain. So does disc degeneration cause pain? So I'm just going to drop down a few of these here. And so young people have different types of spinal pain to older people. So the younger person can have an acute disc bulge with radiating pain, sciatica. That can settle down naturally, although it can be very sore at the start. Over 6 weeks, it can often settle down. It can settle down with an injection of anti-inflammatory medication, an epidural transforaminal injection. And if it doesn't settle down with conservative management or an injection, then surgery is very successful. About 95% of the time, patients get good relief and are satisfied. As somebody gets older, their spine ages and they get bulging of the facet joints and the discs, causing narrowing, and they get claudication symptoms. So nowadays, a lot of surgeons won't operate on somebody with spinal stenosis just because there's spinal stenosis on the MRI scan. They want to know that there's radiating pain down the legs, because your outcomes aren't as good if there isn't typical claudication symptoms. Just as a mention, this MRI scan is obviously somebody who came to me with back pain, but is somebody who got really good relief with facet joint injections and facet joint directed denervation procedures, which I'll go through in a minute as well. But this person has got disc prolapses at 2 of the lower 3 discs in the spine. But this person did very well with facet joint procedures and is actually a very well-known GAA hurler. So, and continues to play, you know, at the national level. So just because somebody has disc degeneration doesn't mean that the pain is coming from their discs, and it doesn't mean that they can't rehabilitate. And maybe that's the difference between athletes and your normal patient, that athletes will do the rehab because they really want to get back to that position, and they're used to using their body in a particular way and moving in a particular way, and they really engage with physiotherapy, whereas it's difficult to nudge patients into that, you know. So here's 3 MRI scans that show, you know, a progression for some people in terms of how spine may age. In the one on the left, you can see disc degeneration at the 2 lowest discs. They're starting to go a bit darker, get dehydrated. In the one in the middle, you can see a patient who may be suitable for surgery because they have spondylolisthesis. So you can see where the 4th vertebra is displaced forward on the 5th, and that's displaced forward on the sacrum. So this would be grade 1 spondylolisthesis. And this is a kind of patient, if they have radiating pain, that might need a spinal fusion. And that's the type of work that Mr. Sitar would do. But this person on the left, although maybe it's hard to see on the slide, if they have just disc degeneration and back pain, they're not really suitable for surgery. So a lot of operations can be done, but a lot of the times patients aren't as happy as you would have predicted them to, or you would have thought they might be. So again, spinal anatomy, I just wanted to show, you know, keep talking about these facet joints. So what are they? They're these little joints here. The nerve roots come out anterior. This is the epidural space, where if you're doing a normal epidural for a lady in labor, you'd go through, that's the interlaminar space. The sacrum is down around the base of the spine here. It's a large joint, and it's supplied by the nerves that emerge from the back of the sacrum. So that's basically what you're seeing there. So multidisciplinary care is really important. So, you know, patients all want to get better with one injection, but some of them do, but most of the time they need that combination of physiotherapy, rehabilitation, and an injection can help to prime them for the rehabilitation, but they do need to use that time and engage in it, because steroid injections really only work, you know, on average for about 10 weeks or so. Some people have a steroid injection and the people come into me and say, oh, I had a steroid injection 10 years ago and it's worked till now. Like, the steroid injection hasn't worked till that time, but luckily their pain settled down or they rehabilitated and they got back to normal. So repeated steroid injections tend not to work as well as the first one. So the first one usually gives about 3 months relief or longer, and then subsequent ones don't work as well. So I'll talk about the other options there as well. Patients are referred to me by GPs, by other specialists, spine surgeons. Physiotherapists can refer to me as well, but if a patient needed to have a procedure done, they'd need a GP letter as well. You know, I liaise very closely with the physiotherapy department, and I'll talk about that in a later slide as well. So the question for me is often, where is the back pain coming from? So it's a combination of listening to a patient, their history, doing a physical examination. In terms of physical examination, if a person has, I'm just going to step to the side here, if somebody has pain on flexion, so I always examine patients because it gives me an opportunity to move, you know, at least 20 times a day, do you know what I mean, instead of sitting down. So I say, feel their back, feel if they're tender in their back, get them to a point where they're sore, and I say, how far can you lean forward? See if they can flex. Most patients can flex. If they have pain on flexion, it can be discogenic because that's the front of the spine. So again here, on flexion, it puts pressure on the discs, whereas on extension, it puts pressure on the facet joints and takes pressure off the discs. So if I ask somebody to now see if you can extend, if they extend backwards and they're sore, it's more likely to be facet joint. So that's the real discriminator there. So targeted injections, which are diagnostic and therapeutic to a degree, identify the source of the pain. So in this patient here, you can see that there's actually there's no disc degeneration, there's no disc bulging, there's no stenosis inside in the canal in the spine. But what there is the facet joints show degeneration at the lowest levels. And actually you can see a bit of atrophy in the muscles as well. The deeper multifidus muscles and the spina erecta muscles have started going fatty, as Diarmuid was mentioning about the rotator cuff. Actually, there's a good bit of subcutaneous tissue there in general as well. But rehabilitating this person will involve getting physiotherapy and getting the person exercising, getting them to engage in a back class, getting them to go swimming, walking, gentle physio, gentle Pilates, gentle yoga, ideally, you know, taught by a physiotherapist to get them rehabilitating. But you can see here that, for example, if this person now, in scans it's flipped around the other way because you look from the bottom, but you can see that the right-sided joint is more degenerated than the left-sided joint. So if this person had right-sided low back pain, MRI scan would be consistent with facet joint degeneration, which is quite easy to treat really with injection therapy. So facet joint pain, posterior column, pain and extension, good flexion, muscle spasm, stiff back, an injection of the joint or the nerve that supplies the joint can kickstart the rehabilitation and be quite useful. There are back pain guidelines in the UK which say that we should test to see if somebody has posterior column pain, and if they have posterior column pain as evidenced by an improvement of more than 50% when they have a medial branch block, then they can have radiofrequency denervation. So I'm just going to explain what denervation is, just because a lot of your patients may have had it done or be thinking about having it done, just so that, so some people would call this the hot needle treatment or call it burning in their back. But basically what we're doing is we're putting in needles alongside the facet joints where the nerve supplies the facet joint, heating up the tip of the needle, and it actually has been well proven to work. There's a lot of randomized controlled clinical trials that show good relief. Now, it doesn't work for everybody, even in perfectly selected patients, but it works for 2/3 of patients and can last on average around 9 months or so. So it's a good treatment. So you can see here that there are needles coming in alongside the facet joint where the nerve, the medial branch, supplies the facet joint, and then by heating up the tip of the needle after testing it, you denervate the joint. So, you know, for most people this can give a good solution. So about 50% of neck pain and maybe about 35% of low back pain, they're definitely facet joint pain. If for the other percentages, there's a component often of facet and disc, and then for some patients it's purely discogenic pain. They are the difficult ones to treat. So this is a picture of facet joint denervation. So you can see that this person here has actually had a artificial disc at L5S1 in the past. So a disc replacement here in the past, and this has to be done anteriorly, so it's done through an abdominal incision. It's quite a big operation, but she did get relief with it for a number of years, and then she started to develop back pain, because what usually happens is that although you've got a solution at this segment, it doesn't really move the same as your normal disc or a healthy disc. So you get adjacent segment disease, so you get wear and tear in the facet joints at the next segment above, because instead of having a spine that moves at a number of different levels, it's moving at less levels. So having to treat the level above is common in people who have a fusion or even a disc replacement. And you can see here actually that on the machine, it's showing that the temperature is going up to 90 degrees. So the standard is 80, but if it's a repeat procedure, often you get better relief at 90 degrees for about a minute and a half. And you can see the temperature goes up, and it basically burns the nerve to supply the joints in the back. So that can be a potential solution. So that basically involves patient lying down. Usually in Blackrock Clinic, they get sedation. Most patients want it. We put in the needles under fluoroscopic guidance, take a lateral picture, test them, and then sequentially, heat the needles. So that's a facet denervation there. So what about acute sciatica? So acute sciatica is another one of the low-hanging fruit of spinal treatment. So somebody who has acute sciatica, it can be L5S1 dermatome, so into the lower back of the leg, into the side of the leg. They can do well with an anti-inflammatory injection, because there can often be, if there's a crack in a disc, if the disc bulge isn't that big, the inflammatory mediators inflame the nerve root and you get radiating pain down the leg. An anti-inflammatory injection can give good relief. A lot of the time, I suppose, patients might go to see one of the spine surgeons and then be referred to me or one of the radiologists for a nerve root block. I suppose, as GPs working around Blackrock or elsewhere, if you have a patient with acute sciatica, it's worth waiting maybe to see if it settles down. If there isn't any neurological impairment, if the patient can stand on their tiptoes and they can walk on their heels and they've got no numbness, although numbness isn't really neurological impairment per se, it's more the motor component which you're concerned about, then if they're not settling down, I would say the easiest thing to do is send them to A&E in Blackrock, because they're going to see an A&E consultant, they're going to get their MRI scan, and then they'll be referred on to either Mr. Sitar or one of his colleagues, or to me. So it's amazing in Blackrock Clinic, we actually have a great working relationship together, and everything works really smoothly. I know we were talking about the need for MRI scans of the hip earlier on, and everybody wants an MRI scan. And the thing is, everybody has an MRI scan by the time they come to see me. So I'm not the person who's saying, oh no, we won't do another MRI scan. I'm usually saying, oh no, we won't do another one. But the reality is that the health economists will say, oh, it's only 1 in 1,000 patients who it's going to show up something pathological. But you don't want to be the person who hasn't gotten the MRI scan in the person who has a pathology. So if the resources were limitless, I would say get an MRI scan. But of course you have to decide yourself, particularly for public patients, on how quickly you can get an MRI scan for them. But I suppose Blackrock Clinic is a bit different, because I remember going up to see a patient on the ward for one of the spine surgeons who had a nerve root decompression in his neck, an ACDF, anterior cervical decompression fusion. And he had gone home after surgery and he had developed another radiating pain in his arm. So he came back in and he basically had pain in the adjacent nerve root. There's a bit of perioperative swelling. It was likely to settle down, but he was very much type A CEO, wanted to have it sorted out, surgery immediately, and we were trying to slow the brakes. So he said, you won't believe it, I was waiting for 3 hours for an MRI scan today. And I was like, okay, if you didn't have Blackrock insurance, you'd be waiting for about 3 years. So, take it easy. But I suppose that shows that there is pressure to investigate people, but as long as they have the insurance, there are the resources as well. So, selective nerve root blocks can work well for acute sciatica. So there's good evidence that selective nerve root blocks work well for patients who have pain which is lasting certainly less than 6 weeks, and it can reduce their likelihood of having surgery. If they have a big disc bulge, it won't cure them, but it can, it can give them an opportunity to pause, see if this condition will settle down. So here you can see a needle going into the L5 nerve root and contrast flow on the left side with this X-ray. So the studies have been done, and they've shown that patients who have small disc bulges can recover naturally, or they can recover with a nerve root block and not need to have surgery. If they have large disc bulges, they're more likely to require surgery. If the disc bulge is over 6.5 millimeters, they're more likely to have surgery. So however, there are patients who recover without surgery, even with larger disc bulges. This lady here, it's not often you get the MRI scan that shows that the disc bulge has resolved, but of course people have a flare-up of back pain, at different stages in their life. So you can see that in the top slide, it's done in May 2016, and in the bottom one, it's done in January 2017, and this is the same patient. So you can see that the disc bulge there was nearly 10 millimeters. This is, quite a big bulge. She didn't have surgery, she had nerve root block, and then a year later or so, her disc is still degenerated. That's not going to regenerate, but the bulge is gone. So her sciatica is likely to have gone, but she still has some back pain. So I suppose what other options are there? I suppose I wanted to talk about things that are new or different. So some people have moderate stenosis, and some people have scarring after surgery. And they're difficult because although you can operate to try to remove scarring, often the body just creates more scarring. So it's a difficult condition. Some people have moderate stenosis, so they don't have severe stenosis, but they still have some claudication symptoms. And what do you do with that? Because there isn't evidence that epidural steroid injections work for chronic radiating pain. They work for acute radiating pain. Some people get better, some people don't. The evidence is kind of mixed. But there is other options. So one of the procedures that I do that has good evidence is where I pass a catheter like a cardiologist would through the base of the spine. So I'm just going to hold up the spine here. So through the caudal foramen and pass a flexible metal catheter. It's got a flexible tip, it's not rigid, and you can steer it up to the place where the narrowing is under X-ray guidance, and then inject a combination of hyaluronidase, which is used in surgery to split tissue planes, and whatever agent you're injecting, usually corticosteroid. And that's called an adhesiolysis procedure. And it can work well for patients who've had previous back surgery or have mild, moderate stenosis. It's not really going to work for people who have severe stenosis. When they have really severe or critical stenosis, it needs to be decompressed. But it can work for those patients that have less severe stenosis. You can see in the top slide here that there's crowding of the nerve roots, but there is still a little bit of space in at the back underneath the lamina and ligamentum flavum. So what's really happening is that the hyaluronidase is dissolving that epidural fat, and it's allowing a little bit more space, and that can be enough to give people relief. In some more severe patients, it's very narrowed and they need surgery. So there are another couple of images of what that procedure entails, and you can see that in the top one on the right, you can see that all of the contrast is bunching together and it's not really flowing, whereas after the adhesiolysis, it's flowing, it looks like a Christmas tree, so you can see that it's spread out. So that can be a useful procedure. So we talked about regenerative medicine earlier and platelet-rich plasma, and there isn't consensus in professional groups as to whether it should be used routinely or not. I use it a bit. I gave a talk yesterday in the Faculty of Pain Medicine about the use of platelet-rich plasma, and up until recently there weren't really any guidelines to go on, but one of the American societies, the American Society of Interventional Pain Physicians, published guidelines just last month on the use of PRP stem cells in spinal pain. And I actually have a few copies of this if anyone is particularly interested and would like to take it away. What I can say is that my feeling on it is that it works as well as steroids. and has less side effects. It's not the miracle cure. There's a lot of fake news out there, and I suppose in terms of, say, stem cells for joints, PRP, there are randomized controlled clinical trials, there's 13 of them, that show that it gives some relief, and that the relief is more than placebo, steroids, and hyaluronic acid, but it's not going to stop you having a knee replacement. It may put it down the road a bit. So if people are advertising and saying, come to me for your stem cell injection, you won't need a knee replacement, that's not true. For, say, younger people with grade 1 or 2 osteoarthritis, it can give good relief and is probably healthier than a steroid injection, but or repeated steroid injections. But it's not going to stop people having, knee replacements or hip replacements long term. That's once it's severe degeneration with big defects in bone on bone, no amount of plasma and stem cells is going to make a difference there. So I think you're going to be busy for a long time to come. Now, I haven't started treating animals in Blackrock Clinic. They haven't opened a veterinary clinic, but PRP injections, people see it on TV. They come in armed to the teeth about what they want, and this is actually a guide dog of one of the patients, but a beautiful little retriever. As I said, there is good evidence that it works for facet joint injections. There is good evidence that it works for sacroiliac joint injections. So what I do is I do the standard procedures, and then if they haven't worked, I'll offer PRP treatment. And then it's up to a patient to decide whether they want it or not. Some people come in and say, I've heard you're doing PRP, I want it, and then I go, okay, we'll go through the risk, benefits, and alternatives, and you can, decide if we'll use it or not. Sacroiliac joint injection is easy to do in clinic. That's using an ultrasound. This is a PRP injection. You can see the clear plasma, which contains the platelets, and then they degranulate and release all of their 200 different pro and anti-inflammatories and growth factors. And some people get great relief. It takes longer to work than steroids, but it tends to work as well. One possibility in the future is possibly intradiscal PRP injections. So it's not a current therapy, but it may be in the future. The prospective trials have got small amounts of patients and short follow-up, but in the future, I'd say in 2-5 years' time, it may be a therapy, because for those discogenic pain patients, there isn't really anything except fusion for them. And fusion is a big enough operation, and if there was something that could be done before fusion that could give them relief, I think it might be an option for a lot of people. So the study, 8-week follow-up, showed an improvement in function. They did, in their discussion, say that they were getting benefits that lasted longer than that, but it's only very early data, so it's a bit early to really bank on it. Spinal cord stimulation. You may have patients with spinal cord stimulators. The unfortunate thing is that often patients are suffering for a long time with chronic pain or chronic neuropathic radiating pain before they have a spinal cord stimulator put in. So at that stage, they've already lost their job, they've already developed a sick role, they've already gone on to strong opioids. The ideal people to treat are young, healthy people who've got radiating pain who want to get back to work. So if they were the only patients who put spinal cord stimulators into, you get great results. But of course, you have to treat people and go through all the options with them. But that's something that we do in Blackrock Clinic as well. This is another picture of the dorsal column stimulator. So basically, the stimulator goes along the back of the dura in the epidural space and pulses into the dorsal columns and reduces the neuropathic pain transmission up the spinal cord and stimulates the centers in the brain that determine pain and improves the descending inhibitory controls as well. So it's kind of a two-way street. So spinal cord stimulation is not at the stage like pacemakers are for the spine, where you can just put it in and forget about it, and the patient can forget about it. Currently, they usually have to control it, program it, choose which program they're using, turn up and down the amount of energy that they're using. So as long as a person is that much engaged with a gadget in their body, it's never going to be perfect. So in the future, actually there is a current product which senses the electrical current going up the dorsal columns and then suppresses it millisecond to millisecond. But that hasn't reached the wider market yet, but that could be a good, step forward. So rehabilitation, as I said, is really important. The Blackrock physiotherapy department are excellent. We have a 6-week back class. I'm sure all of you refer to physiotherapists already. A lot of physiotherapists have a back class or have a class that they enroll people in, and they either teach yoga or Pilates. But I mean, I'm never threatened by somebody saying, I want to go for another opinion. And I'm sure physiotherapists aren't threatened by people saying, oh, I want to go to the back class in Blackrock Clinic, or, it's just another opinion. It's just something else to dip into. And the reality is with spinal pain, it doesn't just happen once. It happens a number of times over a person's life, and they have a flare up and it settles down. So having somewhere where you can send somebody where they'll go through a program, rehabilitate, they might go back again 2 years later, that's really valuable. So next week we're starting the Back to Life pain management program, although we've had referrals in from other kind of areas of chronic health, so we may have to change the name a little bit. But it's a 7-week program. It's running every Tuesday evening, so it's different to other pain programs in that they're often during the daytime. If you're working, you can't go to it. This is going to be 6 p.m. every Tuesday. There's going to be a physiotherapy class for 45 minutes and exercise advice involved in that. The physiotherapist Nessa, she can't be here, but Aoife is here and going to be involved. There's mindfulness class as well. There's going to be an education session from myself, from a pain nurse, dietitian, occupational therapist, and 2 sessions from a clinical psychologist. Often when I ask physiotherapists, what can I provide you with to make your job easier? Often they want to have a psychologist that they can refer patients to. So I think this is a really good thing for the physiotherapy department of Blackrock Clinic, and that for as GPs that you'll be able to refer. I see no reason why you can't refer directly to this program. I mean, it'll be the physiotherapists will look at the referrals, and if they were concerned about something, they could ask me about it, and I could see the person in my clinic. But if you want to refer somebody directly to this program, then refer to physiotherapy in Blackrock Clinic. Because we all have patients who we feel could do with some coaching, but we don't want to send them to a life coach, who we don't know what the background is, or a counsellor, we don't know what the background is. But all the people in this are hugely qualified. Damien, who's the clinical psychologist, is the pain psychologist in the matter. So hugely qualified. And if there's somebody who's got higher psychological needs, then he'll be able to select them out. My wife, Liz, is a clinical psychologist. She works in brain injury, and she says, any patient who's got chronic pain, it's not 1 or 2 sessions with a psychologist. It takes years to get really into what's causing this chronic widespread pain. Look, that's not everybody. You strain your back, you have a back pain, but there are those people who've got the widespread chronic pain who do have maybe a deeper issue and are somatizing to a degree. A couple of sessions with a counsellor or psychologist isn't going to sort it out, but having a clinical psychologist in this program means at least if there's somebody who has high catastrophization, somatization, that there'd be an avenue for referral there as well. And it can be difficult to get people to engage in psychology, because if you say to somebody, I want you to see a psychologist, they'll immediately go, this pain is not in my head. But we all talk about, I feel pain. And your feelings, they're physical, they're psychological, and sometimes they say, well, there's an emotional component to the pain. So, your emotions are having an effect on the intensity of the pain that you're feeling, and you need some help around managing that emotion-pain connection. So sometimes that can help, but this would be a good avenue. That's what I'm saying. So this is the back class in the physiotherapy department, and they're really well set up. I have got, I train as a yoga teacher. I really believe in rehabilitation. I'd love to train as a physiotherapist, but it takes 4 years. So a yoga teacher only takes a month. I've got a video on YouTube for back pain, and a website and all that kind of modern stuff. But basically it's it's really important that patients do that rehabilitation. We can't force them to do it, but we can provide the availability for them to do it. And there's some of the team, including the dog. So listen, thanks very much everybody for turning up. We all have reasons for being here, and we've reasons not to be here. My 5-week-old baby didn't realise that I was going to be here giving this talk, but thanks very much for all your attention, and it's really appreciated. Thank you. Yeah.
Yeah, we might invite Mrs. Sitar and Aoife Brady up for the panel for any questions that might. So Aoife is one of our senior physiotherapists specialising in back pain, and Mr. Sitar is a consultant neurosurgeon at Blackrock.
Yeah, could I just thank you very much to all the speakers and presentations. They were fantastic. Could I just ask Dr. Lynch, if I may, you know, with the facet joint injections, you get the occasional patient who has had discomfort or even pain while having them, and that's understandable. But are there any complications from it? Is there any percentage of all the patients you see that will actually have some sort of complication or have pain from the procedure itself? Just wondering if you had any thoughts on that. Thanks.
Thanks very much. Just call me Tig. Facet joints are very accessible in the spine. You cannot damage the spine by having facet joint injections. Somebody having an epidural injection is a deeper structure, but facet joints, even if somebody has pain afterwards, it's not dangerous. You don't need to worry about getting any further investigations on them. I always tell people and give them information sheets saying that their pain could get worse before it gets better. They're usually well immediately because the local anesthetic is working, but then the local anesthetic wears off and the steroid, the usual thing that you're injecting, takes a week to 2 to work. So, you know, patients have the procedure done, they feel great, and then suddenly the pain comes back and they're disappointed, and they might contact a GP if they weren't able to contact the person who did it, or if it was done on a Thursday, Friday, they might be looking for somebody on a Monday, but the pain will settle down. You know, of course, there are people who have, for example, disc pain, and they're not going to improve with facet joint injections, but there isn't anything per se to do about that, only to wait and see. The denervation procedures, you are burning as about a centimetre cubed area of the back. So although we usually inject steroids to reduce the post-procedure pain in that, people can be sore for up to a month. And recently I had a 87-year-old patient down the country. I work in Kilkenny as well, and he had to be admitted to hospital because his back pain was so bad afterwards. So, but there wasn't anything that he needed to be admitted to hospital for. He just wasn't coping too well at home. So, you know, with facet joint injections, if that's what's been done, there's no reason to worry. If somebody has an epidural injection, there is a rare risk of infection, bleeding, nerve injury. The risk is about 1 in 15,000. It's extremely rare. The only thing you can do is if somebody comes in and says, I'm in horrendous pain, or my legs aren't working, or I can't cope, just send them into A&E. The Blackrock Clinic has an A&E. It has a radiology department. Out of hours, it's not there, but let somebody else make the decision. Because I think GPs are in a difficult position because, say, in the last MPS newsletter that I got, there was a case of cauda equina, and it was actually settled without any fault. The patient was saying, oh, I had gone to the GP and, you know, I didn't have an immediate MRI scan. And, you know, you're in a difficult position because you're almost expected to bring the patient into the MRI scanner and get them done within an hour or something, you know. But I think as a GP, it's easy for me to be in hospital. because all the facilities are there. I was working in doing a list. I often do it down in the angio lab, the interventional radiology lab, and one of the consultant cardiologists, Dr. Quigley, came out to me and he said, I think he was doing a list in the adjacent room, and he was like, I think one of your patients might be having a heart attack. I'm just going to do an angiogram on him, you know? And he did an angiogram on him, and it was clear. But like, that's the level of resources that I'm working in. So it's difficult as a GP. You know, it is difficult because you can't usually say you'll be fine. If you're worried about somebody, facet joint injections, there can't be anything wrong. But a deeper spine injection, I'm not going to say don't tell them they'll be fine, because you know, it's different because you're working with a different set of resources. If you're worried, send them in. There's a full team of spine surgeons, physicians, radiologists. Don't feel stuck.
Thank you very much.
Aoife, maybe you could just explain what exactly is involved with, from an MDT point of view, what's involved in a pain management program.
So the pain management program we're starting next week. First of all, if you do have any appropriate patients, send them in, and we will probably do an assessment of them just to make sure that they're suitable for the pain management program. So I suppose the main thing is we're trying to get those patients exercising and moving. So that's obviously the physio component, but we also want to get the psychological component. We want to decrease the fear of movement with patients. So often it's just talking to these patients about pacing their activities, managing their flare-ups, so just that when they do have a flare-up, that they're not just taken to the bed, that they're moving, that they actually have a plan for these management of their flare-ups, and also that they think about, well, what caused my flare-up, and how can I prevent this in the future. And also, like, we're just trying to get them stronger, reduce down the fear. The occupational therapists will work on relaxation techniques. So often, obviously, there's a lot of high anxiety with back pain. So it's getting them to relax their mind. There's some mindfulness techniques. And then obviously the clinical psychologists will do a lot of that as well. Also, a key member of the team is our pain nurse, who will just talk to patients about, again, when they're in their flare-up, what they do with the flare-up, like what medications they should use, and that they should be trying to use their first-line medications before going on to their higher opioids and that. And it's just to give some more education and background about pain medication and how best they're used. And I think that's yourself. You'll obviously give a talk just about pain physiology. So I suppose the exercise component will be about 45 minutes, and then about a half an hour talk afterwards, just to talk about different aspects of pain and how we manage it. And then obviously if there's any major problems that we view psychology-wise, we can obviously get Damien involved and refer that patient then. So just overall, it's just that holistic approach to the patient, that they're not just getting physio or not just getting psychology intervention.
Hi, good morning, and it's a nice talk from Dr. Lynch here. Heard about all the chronic pain management, and we as a neurosurgeon and a spinal surgeon feel so happy that there are pain specialists who can look after the chronic failed back here. I just make few comments from our side. As Dr. Lynch said, by and large, when the patient comes with the back and leg pain, acutely, we don't operate in the first 6 weeks. We give a time. But there are 3 main indications which we need to consider, and patients require and surgery within the first few weeks after the start of the back and the leg pain. The first most, the patients have a foot drop or a numbness or start dragging his foot as well. The second one have a classical cauda equina with a bladder involvement or a saddle anesthesia or a numbness in the private parts. Now the third indication is a gray, again decided by the individual spinal surgeons. We ask the patients about the severity of the pain. If the pain is so much severe that is affecting the quality of the life, and at the same time, the history, examination, and the MRI finding, they all correlate. There is a big disc, and if the patient said that I cannot take that much non-steroidal, I have a problem with my stomach as well, or patient is on heavy opioid, his quality of life is really miserable, pain is such severe, the intensity with the scale, and when you correlate with the MRI finding, you said that patients need a surgery, and we as a neurospinal surgeons, we deal with this. And I have done, I would say, hundreds and hundreds of patients as well, yeah, both in the public and private. And there is a good result as well. And the patient go home either next day or in a couple of days seeing the physio, and they do well and they discharge after the 6 weeks of clinic as well. So selection of the patient is so important. History, most of the time, more than 90%, we can get where is the problem. Patient can have a joint problem with the hip as well, but when we inquire more, say the problem is coming from the spine, and when we examine the patients and we see all the signs of the sciatica as well, with the weakness and numbness and reflexes and so on, and when the patient had MRI of the lower back, lumbosacral spine and the hip, and that can show as well. One other things I would say, we deal the acute disc as well, and I saw one of the slide, and I have come across myself as well, the patient who had a large disc, and lady did not decide to go under surgery. In other group, waiting long time in a public sector, and when the time comes, the leg pain has gone, and when we repeat the MRI on the same morning of the surgery, just only dark disc, degenerated disc, but no prolapse. And we know the natural history of the disc disease, that if we don't operate in the first 6 weeks, most people do get better over the period of time with physiotherapy and psychological therapy as well, and weight reduction. The most important thing in the physio, what I tell, that the core muscles of the lower back needs to be strengthened to that degree that that can take lot of burden of the back pain and lot of burden from the facet joints. So weight reduction and this physio with the core exercise, the swimming, walking, and these can help as well, yes. Thanks.
Thank you.
And just to add to that, we do Pilates classes as well in physiotherapy.
We've got one more question from online. It actually pertains to more the knees. So it's from Dr. Matthews. You mentioned removing the posterior cruciate with a knee replacement. Can you comment further on this, please, regarding implications for stability, hyperextension, and rehabilitation post-op? Would one of the...
None, really. It's a technical nuance. You're basically, with the prostheses available are either cruciate retaining or cruciate sacrificing. All of the studies, all of the registries, all of the follow-up data, it's all exactly the same. In the vast majority of cases, it's nothing more than a matter of surgeon preference.
Okay, thank you. Thank you very much. Thank you everyone for coming. I think the talks are all brilliant this morning, so thanks very much. Like I said, we're reaching out to all of you in regards to our orthopaedic and spinal services. If there's anything that you think that we could improve and do better, please come and talk to us. But again, thank you for coming, and thank you for watching online.